Please see him. He's a good man and thorough.
So, welcome to the podcast. How's it going today?
I'm great. How are you doing, Joe?
I'm doing great. So, I did some research in preparation for this. I Googled you and did some deeper research with AI. And evidently, you are responsible for more orgasms than anybody west of the Mississippi. Is that right? Tell me about that.
It's true. I mean, I'm working on it. I don't know that I have actually achieved like the most number, but I'm working on it. It's a goal.
So, tell me about that. How are you achieving that?
So you want to talk a little bit about where I work, what I do?
Yeah, I mean, how did you get this reputation? How come that's the top thing that comes up when I Google your name?
Well, so women
By
come
the way,
in.
everybody, Allison Imel, not Immels. There's no S. It's just Imel. Allison Imel. You're a PA, is that right?
I'm a PA, yep, in urogynecology.
Okay.
So I see a lot of women who have vaginal dryness, who have dissatisfaction in their sexual lives, or they don't want to have sex at all, and think that it's done. They like, oh, we're fine. We don't need to do that anymore. So whether or not they want,
There's women out there that aren't interested in sex.
there are so many. I think the thing is though, I don't think that they actually are not interested. I think that there's this, I think there's an acceptance. Like it may be just like a surrendering, but not in a positive way. That just, it's over, or their partner doesn't want to do it anymore, or it hurts too bad. That's the main complaint, is it hurts. So they start having pain.
They could be interested.
Yes, and most of them are. And I think that once we start treating and we start talking about other things, because they come in with other complaints, then all of a sudden they're like, oh, I'm not, all sleepy down there. And so their interest starts to improve.
So you're telling me there's a chance?
There's a chance. Yes.
Okay, cool. So, but the last time I saw you in person was, I think, pre-pandemic. Yeah.
Yeah, like right before. Yeah.
In Portland at Kennedy School.
Yeah.
Yeah. So, but back then, if I recall, weren't you deeply involved in spinal surgery?
Let's see. I just started assisting in neurosurgery, but or spine surgery. But I had my own functional medicine practice at the same time.
Right. That's how we met, was at a functional medicine seminar.
Right.
So how did you end up going from functional medicine to spinal surgery, like neurosurgery assisting, to what you're doing now? And like, what are you doing now exactly anyway?
So right now I work in urogynecology and pelvic floor medicine for a big healthcare system. And that's actually what I wanted to be doing when I got the job in spine surgery. So I have a background in functional medicine, functional nutrition, but I also really loved the OR when I was in PA school. And so I wanted to get back in there and not lose my skills. And I wanted a urogynecology job, but I also had a little one at home, and so the schedule was really demanding. So I took a job in the OR with spine for 3 days a week, and then I worked on my my functional medicine practice on the side. So after the pandemic and just not loving orthopedics, because it wasn't actually a first choice, the job opened up again in urogynecology, so I took it. That's where I really want to be.
Right on. And so you went from functional medicine, and stayed with functional medicine, then added on this orthopedic position, but wasn't your first choice. And then when this other position in urogynecology opened up, you're like, yes.
Yeah. Yeah. And it was women's health and urogynecology. So doing a lot of gynecology too. At the same time, I don't have the same passion for that. Just because and you and I are trained similarly. It's like I would see a lot of like the end state. It's like where people they'd gotten way past the point where functional medicine could really help them. And so surgery was often the only option for many of these people, or it was just kind of late in the game. In urogynecology, you can do so much with lifestyle and incorporate functional medicine up front. And a lot of the gynecologic pathology, it's really hard, especially as a PA trained in functional medicine, kind of coming from the outside in and trying to practice differently. Because I think where functional medicine really shines in gynecology is prevention.
Okay. Well, so, can you explain to everybody what functional medicine is?
functional medicine is root cause medicine. It's really, I like to use my hands and I'd be like, it's like taking everything out of the box, just looking at everything at once. And it takes time. It's understanding people's story. It's looking at the way that their nervous systems work, their immune systems work, their gut works, what their environment is doing, the genes they came into the world with, how those genes are affected by all those things, the environment, diet. But I think that the practice of functional medicine, that's like the concept, but the practice of functional medicine is listening to the patient, understanding what the patient's days look like, and where their food choices come from, what they've been exposed to understand why they're manifesting these disease symptoms.
Well, what do you mean listen to the patient? That's not, who has time for that?
Right. I do. I plucked myself, I just right into subspecialty in healthcare. It's the only place where we get time with patients. It's amazing. It's like the whole 5 to 15-minute visit thing in primary care. That doesn't happen in
It doesn't
specialty.
happen in your specialty, in your role, or at your facility?
I think it's really actually common in subspecialty. So urogynecology is a subspecialty of gynecology and urology. And so it's a place where people come when their primary carers can't figure out what's going on, or the disease or the condition is just not resolving with the skills or the tools that primary care is using. So we need more time to figure it out. So similar to functional medicine, where you get all this time to kind of unwrap and unravel things to get to the root cause of the issue, I have a lot of time with these patients. So I get to ask them a lot of questions. It's a sweet, sort of vulnerable space and I work with only women, but it's a sweet, vulnerable space for women to come in and tell their stories. And so we have tissues for sure in every room. And
So it's like Barbara Walters special.
it's not quite that
like Oprah. It's like
interrogative.
Oprah, you got a couch. It's like an Oprah Winfrey episode. Like people are coming in there and just kind of letting out.
Yeah. Except that they're undressed from waist down. So,
So it's a little different.
It's a little different. Yeah. But it is a safe space. I mean, it's creating the safe space to hear. And I think that so many women are afraid to talk about these issues. So, we're dealing with incontinence issues, painful sex, just vaginal pain, vulvar pain, pelvic pain, interstitial cystitis, painful bladder syndrome. And
interstitial cystitis is where somebody would pee like 30 times a day, right?
Well, it's a little different. That's like simply stated, that's urinary urgency. It's where someone has to go all the time. And then it used to be called overactive bladder. Interstitial cystitis is more of an immune mediated issue with the gag layer of the bladder. So similar to all these mucosal surfaces in the body, there's this really protective layer in the bladder, and that gets inflamed. And I would love to talk about that. But I don't want to get too off track, but all these conditions that these women come in, they are not comfortable things to talk about, especially if you're not close with your primary care, or if you don't have a whole lot of time. It's like you're dealing with managing your blood pressure and your prediabetes, your diabetes. It's like, by the way, I can't leave my house because I leak all the time. By the way, every time I stand up from the sofa, I'm leaking urine, or I can't have sex with my husband anymore because it's too painful. It's like these things are lower on the list, the priority list for women when they are going to the doctor. Mm-hmm. So they often don't get talked about. So they'll go years. This is another thing we see is years without diagnosis or assessment of any kind. So women are suffering.
Because they go years. So let me try to understand this. So you're saying that as a functional medicine practitioner, you're able to take a little bit more time and unravel the underlying cause of what's driving their symptoms, as each case, even though the symptoms are the same, there's different underlying causes. And so you're able to get a little bit more to why they're presenting with having a dry vagina or painful sex, if the painful sex is from having a dry vagina, or why they have sudden leakage. Whereas before, how is what you're doing different than what generally is available to women? I think it's really important for them to understand that. I understand a little bit more about functional medicine based on what you're describing there, but like, how would you approach, say, a woman came to you with both painful sex, pain during sex, and issues with leakage? How might you approach that in a way that is different now than what maybe women had access to or typically have access to?
So it's actually a complex question, because I feel like the urogynecology field does a really good job of looking at multiple issues, or, in general, the field takes a multifactorial approach. So, I think the functional medicine training allows me to ask lots of questions and not just say, oh, you have overactive bladder. Okay, did you take out bladder irritants? Oh, you did? You tried that? Okay, great. Now let's try you on medication. Instead, what I'm doing is asking deeper questions. If they're still having issues with, incontinence, even though we already reviewed taking out bladder irritants, I ask again. It's like, I'll ask.
What would be an example of an irritant?
Artificial sweeteners are the biggest ones. I mean, these artificial sweeteners and everything, not only are they bladder irritants, but you and I could go off on artificial sweeteners, I'm sure.
Wow.
But that's the biggest one. So, but we do an intake, right? And we ask them any artificial sweeteners. And if they're still having issues, and I'll ask them again in the interview. And then when they come back for follow-up, I will take note of the things that they said that they were drinking, or I will just, have to follow up in 3 months. And they're typically still drinking them. Or I'll be like, is there anything else? Like, let's walk through your day. So this is where the nutrition, the functional medicine comes up. Like, let's walk through your day. What are you eating? What are you putting in your coffee? And it's still there. And so just not taking, I think a lot of times, because in conventional training, we're just, you ask a question, it's yes or no, right? And then you move on to the next one. That it will get missed all the time. Like, things will just get overlooked, and then you're headed to second line therapies and third line therapies. You go back and you're like, people are in the OR, right? They're in the operating room. They're getting modulators implanted into their bodies. And no one ever asked them if they stopped drinking Diet Coke.
So you're saying the sweetener, what I'm hearing you say is the sweetener in Diet Coke, for example, or maybe the artificial sweetener in like chewing gum, could potentially, for some of the people that you see, be the mechanism that causes them to have leakage.
Yeah.
Wow. And so how does that work? Like, do you know what it is in the sweetener that causes bladder to irritate?
I mean, we know that like aspartame, sucralose, what's the new one? Nematame, something like that. It's not new, but these artificial sweeteners are neurotoxic. We know that they're neuroinflammatory, right? So they are, the way I describe it to patients is they're interrupting the communication between the brain and the bladder. So this is all nervous system regulation. And
Interesting.
So the way I describe it to patients is like the communication between the brain and the bladder is like a highway. Like, say you're driving down West Texas, and it's like you can go 90 miles an hour. You can see way far, far off in the distance. It's like, there should be no obstacles. And that communication should be clear, right? Drink water, bladder fills, time to empty, it empties. But if you drink artificial sweeteners, it's like throwing firecrackers on the highway. So you're driving on the same highway, same car, same destination, but you're having to constantly swerve. And so it's this really confused message. It's this like jerky pathway to actually get the message from the brain to the bladder. And so a lot of people, they get a little bit of fluid in their bladder, and then the bladder's like, okay, it's time to go. Oh, it's time to go again. And so then people are like, oh my God, I have to pee again. Oh, I have to pee again. I have to pee again. So you take that out, the lines of communication get a little smoothed over. People get better really fast. So it's not the only thing, but.
So right, it's not the only thing, but it's one common mechanism that probably isn't being discussed for a lot of folks. Yeah. And it sounds like it may be discussed briefly and then kind of onto the next thing, and it isn't emphasized enough. I see this a lot too with hormonal issues that are repetitive, that, there's this thing like one simple question: how do you feel after you eat? Do you feel energized, or do you have better memory or better mood and not just full? Or do you feel really fatigued after you eat? That's like a core question that I would ask somebody that has hormonal issues. And if they have that issue, then they're going to end up in some sort of blood sugar induced stress chemistry that will lead to a alteration of their sex hormones that can be a primary driver. Generally, right, when we're working with clients, it's like, it's not as simple as it's going to be one thing. But for that patient, there might be one thing in that moment that's the key that unlocks the whole thing. But it's probably more of a mosaic of factors, and you just got to turn over enough of them to see the clear picture than it is like a smoking gun. But if we can't identify enough of these big factors, then it's like we strike out with that person. Like, for example, let's say you worked with somebody and they had this issue with the sweetener, and they also had like E. coli or something living in their bladder, right? So they do the job with the sweetener, but then the bladder E. coli infection is still there. So the sweetener thing didn't pay off for them because they still
Yeah.
had symptoms, and then they just give up on that whole thing. And then they go on and they resolve the bladder issue with whatever therapy works for them with their doctor, and then they're still on sweetener. So now the bladder issue is resolved in terms of the E. coli infection, but they're back on sweetener. And then they're just like, they basically put their hands in the air and they don't know where to turn and don't know what to do. And the idea that the bladder actually is doing what it thinks it's supposed to do with these different things going on, and continually, relentlessly, and systematically identifying the factors and then addressing as many as possible to get them out of a symptom threshold becomes the whole gig, right? And so, but like, gosh, how are we supposed to do that as doctors in a 15-minute visit?
Right. Impossible. Impossible. Yeah. I mean, that's the thing. We spend an hour with new patients and they leave kind of, and I always say, I'm like, I know this is overwhelming. Like, I'm sorry. There's just kind of no other way, but here's a lot of literature. I'm accessible for questions. Come back and see me. If you don't want to wait 3 months, come back and see me. But an hour, and it's still not as thorough as I want to be. Yeah, odds are you're not going to resolve the E. coli thing if you're still on the artificial sweeteners. Just staying.
Right, it makes sense because it's just going to feed the beast, right?
Yeah.
So
The research is showing that that new sweetener that's like an aspartame sister actually penetrates into the cells of the beneficial bacteria, and it causes cell death in the lactobacilli. And that's those the lactobacilli are the guys that are pushing the E. coli out. So if you can't proliferate lactobacilli, then you can't get rid of the E. coli.
So lactobacilli doesn't proliferate if there's too much of the new sweetener present.
Yeah. That's all of them. I mean, that's pretty much all of them.
So what do you do when you're sitting there with your patient and they got one of these drinks on hand?
No one does. I have actually never
What about
seen
your new patients? Listen, new
Yeah,
patients.
I'm just saying they don't. I mean, I haven't so far. The coffee drinks with the sugar-free pumps, they'll come in like that. But it's kind of funny. No one's ever, because I've never. Maybe I have. But it's been at least a year and a half where I've pointed out to someone, be like that. Because I don't want anybody to ever feel shame or judgment either, because it's education. People just don't know, and I truly believe that. I think that I would say 90% of the time, if they know, they are willing to make the change. But if you don't know, you don't know.
Well, I guess that's where we differ. My strategy generally is to browbeat patients with shame and humiliation until they, begrudgingly, defeatedly, in a resigned way, walk out.
Well, I know that that's not true about you. So,
the word doctor is Latin from docere, which means to teach. So, right. So, like,
right.
I think that's one of the things that I appreciate most about you, and why I'm so excited that you agreed to do this, because more than, I mean, look, it's a pretty special space, the functional medicine space. Like, it's a privilege to teach these seminars, and I meet amazing people wherever I go. And it's a pretty, dedicated crowd if they're spending their weekends, their spare time learning this stuff. But I can tell, like, you're super into it and you're into the education piece. You're not just looking for a protocol. You're looking to get a conversation going that could be helpful. I do appreciate that you're non-judgmental, and your bedside manner is impeccable. So, and I've heard this, so I think it's really cool that you have this new thing coming up. So tell me, what is this new thing that you were really excited about? That I said, no, let's not talk about it now. Let's talk about it later when we're on camera. Like, what is it? Tell me.
Yeah. Well, I think the thing that's happening right now that is really exciting is this big healthcare system that I work for has allowed me to come in to build a metabolic wellness program. And what that means is that I am helping reverse prediabetes, insulin resistance, body composition dysfunction. I don't know if that's actually the right term for it, but
You're working on metabolic syndrome, you said?
I am working on metabolic syndrome. Yeah. So the goal was to help women with their metabolic health. And this is where there's a huge paucity in primary care, right? It's like no one's really looking at everything. You're checking labs, and they're very simple labs. They're not, you're not checking lots of labs, and you're not necessarily running all the right labs. You're not asking women about their stress and their resilience to stress. You might say, "Oh, are you stressed?" Yes. Okay. Well, here's an antidepressant. We're saying, what are the things that are getting in your way? What are the resources? We talk about currency of time, energy, space, and money. It's like, what do you not have enough of? What's getting in the way of making these choices? Because everyone knows they need to eat well and exercise. So the program we've created allows us to build community. That's really important. I strongly believe that people heal faster and better in community. So they have community. It's a 12-week program. They get to meet 6 times over the course of 12 weeks. We run all of their labs, beginning and end. We're measuring body
community. I don't mean to interrupt you, but what do you mean by community? You're saying they have
we're doing a group.
You know what's funny? What's funny is I feel like this interview, it's kind of funny where I watched this interview of Jordan Peterson one time, and the woman kept saying, "And you're saying," and it wasn't what he was saying at all. And so I swear to you, I'm not trying to put words in your mouth. Okay. But let me try to understand this a little bit better.
Okay.
What do you mean when you say, because this is not a gotcha interview?
Yeah. Like, what do I mean by community?
So what do you mean by community? Is there you said 6 times they meet where a number of women, like how many women? Is it like 2 women? Is it 10 women? Is it 15 women?
Yeah. So
how long is the meeting and what do they do in those meetings?
Let me tell you. Oh my gosh.
That's revolutionary, because that's a way for people. I love this because the thing is I really feel like there's a little bit of an it sounds funny, but there's a little bit of an over reliance on doctors to solve everything. And the reality is, like, if there's a community of people dealing with the same thing that can support one another through the process, talk about trade ideas on food plans and on exercises and things that work for them, battles they've had. I love it. So this is really, really, really cool. So tell me more about this community that you're building.
Well, I want to first give credit to the inspiration. So the Cleveland Clinic did this, and they found that people were healing way faster in 10-week cohorts than they did in 6 months of working one-on-one with someone. So, and then the book by James Maskell, The Community Cure. Like there's a lot of this data. The Community Cure by James Maskell. He talks a lot about this. There's tons of data in there. So, we have a special education room in our clinic, and it really only fits, like, we're kind of limited by the space. We have enough for 12 chairs and me. So we started with 12 at the first group. It kind of fell off to 2 people were like, they did their one-on-ones and they were like, I don't know if I'm ready for this. Like, that's fine. And then we had 10, and then 2 people couldn't make it. Life happened. So we had a solid core group of 8 women, and they showed up to every single visit. And we started in a circle. So I really was trying to hold the space for like a council. I love the idea of council for women, for men too, but the women's council.
All right.
And but then we started taking too many notes. They're like, Allison, can we have the table back? I'm like, sure, no problem. We'll bring the table back in. So
you're all just sitting around in a circle, and then you're like holding the cons. Like, what is it like?
Yeah. Yes. Like holding the talking piece. Yeah.
You have a talking piece? Do you really have it?
No. I'm going to get, but I will get a talking piece, but this is something that
should go a long way. I'm just saying, like have the
Yeah, I have one back in the backyard. I can just take it. Yeah. Perfect. But it's 2 hours that we meet, and they come into clinic and they check in just at the front desk, just like they would, and they get a copay and all that. But then they come into the conference room. We shut the door. They make a cup of tea. I've got snacks out, low glycemic, anti-inflammatory snacks out.
What kind of tea are you rolling out?
Kind of teas?
Yeah.
Mint teas.
Are they caffeinated or not?
No. Just herbal teas.
Have you heard, is this true? Because I heard it's true that some teas, I'm sure your teas don't, but some teas actually have plastic tea bags.
Yeah.
So like people will, and then what they'll do is they'll heat their teapot. Their teapot has a little plastic indicator in it. And then they have a tea bag that's plastic, microplastic. And so, like, can you imagine? This kind of reminds me of when I was in North Dakota practicing. I reached out to the Diabetes Association of America because I wanted to help them with like the metabolic stuff that you're working on now. And I said, look, there's some really interesting solutions for a lot of people with type 2 diabetes and also type 1 and type 1.5 and type 3 diabetes. And they said, oh, there's going to be a cure. There's going to be a cure any day now. This was 2005. I'm like, okay. And then, but when I went to this event, all it was like, there's just all these snacks in the back. It was like a carb fest. And they had artificially sweetened drinks. So I wonder how many people left this event and had bladder urgency based on what you're saying. But like,
None, zero.
but isn't it
Oh,
wild?
your event. Yeah, your event. Yeah.
So can you imagine like going to one of these hospitals, and I'm sure that Cleveland Clinic isn't doing this, but like you just go to these places and like there's a lot of well-intentioned stuff going on. But then like I had one example of a male, it wasn't a female, but a guy who suddenly lost all of his hair. And what we found out was he found this out later. Like I thought it was because it was the start of the pandemic and he had his favorite restaurant made like this, it was like this Chinese restaurant that made this soup that he loved. And he couldn't go there and eat anymore. So he was getting like these big giant to-go things in plastic. And he was just heating up the plastic and heating up the soup and eating it out of the plastic. And exactly, that's the look I made. I was like, oh my God, that's why you lost your hair. And it turns out it wasn't that. It was he had just bought a new teapot that to replace the one that had plastic, but it had some weird lining on the inside of it. And once he flopped out the teapot, his hair grew back and he actually started to grow facial hair back too, but in a weird pattern that the only part of his facial hair that was dark was right here. So the rest of it was, so he walked around and people thought he was growing like a Charlie Chaplin or Hitler mustache.
Uh-huh. Bless his heart.
And so it's just like, but this is a client who I talked to recently that told me after the fact. And I just think it's so cool that you've created all this time to meet with people and talk with them, and you're creating all these resources for them because you need time to work through it and figure it out. And then you also need a facility like you have that supports you, that allows you to have the space and time to do it. And then even provides resources to make the experience a little more enjoyable instead of just like a room with a bunch of uncomfortable chairs. I could just picture a room with like folding chairs that are uncomfortable and a lot of urinary urgent women, having to buzz out of there quite often. And then there's like a little bit of when women get up to go pee, is it kind of like, darn, they're still peeing a lot? Or is there any of that moments when you're having these talks?
No, and I'm not, this is a cohort that's coming from the primary care clinics.
Okay,
so
I
it's
got
not
you.
necessarily, they're not all presenting with the same, like a urinary issue. These are all
Okay.
women who are diabetic or pre-diabetic.
I got you. So I don't mean to interrupt the story, but I think it's
You're
really
fine.
cool. And I learned yesterday, 2 days ago, something I learned new on a healthcare forum about dandelion tea and how dandelion tea can block COVID spike protein from binding to ACE receptors. So like it might be a good idea if you have COVID currently, and of course I can't advise you on this, but there have been people that have swapped out the caffeine and have gotten on
Roasted dandelion.
this dandelion tea, and it seems to help their symptoms. And I've found that to be pretty reliable when I talk to other clinicians. So that's just something. Do you guys have any dandelion tea in there?
I do. It goes
Oh.
fast though, because it's my favorite too. So it's the one I always
What's your
pick.
favorite dandelion tea?
My favorite tea I buy in the cases, but I need to get a different kind because I think that I heard that the wrapper that mine comes in is not compostable. So I'm like, it actually has plastic lining. There's no plastic in the tea bag, but there's plastic lining on and I think it's just so that it doesn't break down. So it actually protects the
On the
tea bag.
bag?
Yeah,
On
I'm a
the
huge
can?
roasted dandelion root tea person. Oh my gosh, I am. Yeah, there you go. I love roasted dandelion root tea. I've been like singing his praises for like 20 years. Every night before I go to bed, I make a cup of tea. When COVID was going crazy, Dietrich Klinghardt was like screaming, dandelion, 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 and even in tincture form. So
Oh, okay, that's right. I forgot that you worked with him.
I
Well, you
didn't
studied
work
him.
with him, but I studied.
Yeah.
Yeah. Mhm.
It's
We
interesting.
chatted in his clinic.
Did you hear anything about how mint tea can be estrogenic?
Nope.
I've heard that, and I've had some women that have engaged in a little bit more mint tea, trying to make some changes, and sometimes they get more estrogen positive symptoms from that. I'm wondering if
Huh,
you
that's
at all.
interesting. I do know that mint tea, it can irritate the lower esophageal sphincter. And when we're talking about estrogen metabolism, it's like it's totally a north to south process, right? Like if your digestion is compromised, then you're not going to be secreting healthy bile, and your estrobolome going to be off. And
Right.
so I don't know if maybe it's not so direct. Maybe it doesn't have to do with that. Maybe it's more of a
Estrobolome, you mean, is the microbiome
estrobolome,
and its influence on estrogen metabolism, right?
right?
This is something I wanted to talk to you about, actually. I guess
Great. What a
talk about
segue.
it now, but I don't want to get too far off the community story. But like, one of the things that I find is a huge factor, both in men and women that are dealing with estrogen positive stuff. So like men who have large prostates, or like they're extremely moody. They're just like estrogen dominant men. Um, or women that are like having significant pain during their period, and like breast tenderness and excessive blood loss and clotting. And they've maybe had a history of being on the pill and it didn't go well, like extremely poorly, like they gained a ton of weight on the pill very quickly. And people that are having a hard time losing weight, like with the metabolic diet, that something that we often would recommend for people, like a little bit more of a carb restriction. I find that they have in their stool testing elevated beta glucuronidase, right? And so
Mhm.
that beta glucuronidase is an enzyme um, made by the microbiome, or the estrobolome, and that can cause recycling. So imagine like your body does all this work to pull it makes estrogen, or you're exposed to it in the environment, 80,000 different estrogen mimicking things. You put it into your liver, you excrete it into your bowel from your gallbladder. All that needs to work. You go through all this trouble and energy to get it there. And then the microbiome's like, screw this, man. You're going back. You're going back. You're not going out to the toilet. Like you got another chance. And so it sends it back in. And so then you can't get rid of this estrogen. And so you have so many people with estrogen positive symptoms. And then they go on progesterone cream, which is like dosed in micrograms instead of picograms, which is like 1,000 times more powerful. And they end up with two excess hormones, downregulation of their progesterone receptors, and an excessive aspect of estrogen signaling. Like, I don't know if that's what happened with Suzanne Summers, right? But you hear about like this hormone replacement thing. And I wonder, is that something you're seeing a ton of in your practice? And like, are you doing testing around that? Or is it just something you're aware of because you're in the functional medicine community?
I'm not doing a lot of that in my practice now. I do a lot of vaginal estrogen replacement, but as far as like hormone replacement therapy, I do just a little bit, and we're talking like minimal dose, minimal effective dose. I don't have the capacity to do a bunch of the stool testing and the Dutch testing where I am, like the urine metabolite testing. Um, but everything comes back to the foundational stuff. It does. Like women want, a lot of people walk in and they want hormone replacement therapy to fix things, and it's like, gosh, their guts are a mess, and they've never ever even had anyone evaluate their phase 2 liver detoxification, and their stress is on high. It's like, you have to deal with insulin, cortisol, and gut before you start messing with the reproductive hormones.
What do you mean by that? Can you talk about that a little bit more? So you're saying that before you deal with sex hormones, you want to deal with insulin, which is what we release when we have high carbs, or sweeteners at all, even without carbs.
Mhm.
Cortisol, which is our stress hormone that's produced when we're stressed out, or first thing in the morning when we're fasting, and your gut. So what do you mean by that? Do you have a prioritization there within those three?
I always start with blood sugar regulation, because the nervous system stuff, like changing people's wiring, that is more work. That's heart work. That's soul work. That's trauma work. That's, We even talk about chakras in urogynecology, and I love your little glasses you got behind you. So blood sugar regulation, number one. I was trained by the Nutritional Therapy Association way back in the day, and these are like core fundamental principles of wellness. Like regulate your blood sugar. The body likes predictability. So most of these people they want to fast to lose weight. It's like, oh my God, you cannot fast yet. Like you don't even. We're not there yet, right? They can't stabilize if their blood sugar. If they fast and their blood sugar drops, their cortisol is going to spike, and then that's just they're going to be bouncing all over the place.
Why would
So a lot
somebody
of
have a problem with cortisol if they fasted, if they have a blood sugar problem? Can you
say that again?
Why would somebody who's trying to lose weight with a blood sugar problem, like, can you explain the mechanism of how fasting would mess their stress hormone up as you described?
I mean, if you're already running high on stress anyway, and you're kind of wired for hypervigilance, then this fasting actually tells the body like, oh my God, we don't know when food's coming, like store fat. So their blood sugars, every time their blood sugar drops, because they're not fat adapted, or they actually can't, their bodies are so used to snacking, or they're getting this information, and it's just information, right? It's just data from sugar and artificial sweeteners and stress and stimulus and whatever, phones. Their bodies are just used to having something, and you take all that away, blood sugar drops, and the body's like, ugh! So cortisol levels spike up, and it's gonna promote cravings. It's gonna promote gluconeogenesis. That's so just producing, taking your storage of your sugar storage from your liver and putting sugar in the bloodstream anyway. And then it's going to tell the body to store fat.
Where do
So
they store fat in that situation typically?
right here,
The old spare tire?
here. Yeah.
In the back? The old back straps there? Okay.
Back straps in the belly for sure.
Okay.
And that's where a lot of women, I mean, men too, but like that's where we start to see that in that perimenopausal period, right? So after age 35, that resilience to stress kind of goes down, that tendency towards cortisol production goes up, and now we're really more focused on surviving each day rather than optimizing our reproductive hormones. So your periods start to get less regular, and you'll start to see all these hormonal symptoms. That's why women want to start tending to their hormones. Like, oh my gosh, my hormones are off. My hormones are off. It's like, yes, they are, but it's your cortisol and it's your insulin. And so, I mean, you can jump in here anytime.
People out, because I think people want to hear the hormone sexy story, but much like we talked about earlier, it's just so true. Like if you go in to your clinic and you have this bladder issue, and the issue is due to something really basic, like you're eating artificial sweetener, then it's not going to get better. I can tell you my experience also with blood sugar is that most of the chronic cases that get referred to me by other clinicians, where they failed was to reestablish healthy energy production. And when they have either insulin resistance or reactive hypoglycemia, which means their blood sugar drops too much in between meals and they release stress hormone, they will not recover. They're going to constantly be in stress chemistry. Stress chemistry is not rest, relax, digest, absorb, and heal. They're going to end up with more food sensitivities, more weight gain. Unless they're like the type of person that doesn't gain weight, that other person's going to lose weight. They're going to start eating their muscles. They're going to lose weight. They're going to lose muscle mass. Both of them are going to be depressed. They're either going to have a lot of like poor energy. They may be anxious. And it's just like, it's such an important conversation because literally it's the foundation of health and vitality is to have stable energy production. You cannot burn fat. If your glucocorticoids are high, you're going to be biasing sugar because your adrenals are involved. And you're dumping all of this stored sugar from your liver, and then you're basically storing it around the middle. And you have somebody who like goes into this situation. So like the key thing for insulin resistance, you have it if you eat and you feel tired after you eat, or you crave carbs after you eat. That's like insulin resistance, right? The key question for reactive hypoglycemia is, I'm starting to not really hungry, but I'm starting to like lose energy. My memory isn't so good. My mood isn't so good. I'm hangry, and then I eat and I feel better, or my energy improves. That is the person that if they started fasting, they would completely fall apart, or worse yet, they would feel better for like a week or 2 weeks because they're living on adrenaline.
Yeah.
And then they just crash and burn. And all the while, their hormone issues are getting so much worse. Their autoimmunity is getting worse. Their leaky gut's getting worse. Their leaky brain's getting worse. Their dementia potential is getting worse. And it's almost like a disaster, and then they go online and they're on like TikTok or they're on Instagram and they're listening to influencers that
I know
have
it makes me. I just like
in their
I'm like
life.
getting a little more clips. It's just like it's so. You and I both we feel the same passion about this. I mean, I can feel my stress levels actually rising. My cortisol levels are rising just thinking about it. Right, I'm like,
Okay, just breathe.
and
Breathe.
and here's the problem. Everyone wants somebody to tell them what to do because no one is really. And I'm making a huge generalization, and I don't mean to blame anyone.
Come on, just let us have it.
But people are not willing to accept responsibility for how their choices are affecting their health. And there's so much shame around food choices. And I just, oh, it just makes me feel good. Oh, but I love cheese. There's just so much emotion just
It is interesting.
tangled.
It's interesting. Not only that, but like there, I agree. I agree that there is an element of responsibility, personal responsibility that seems to be missing. And so generally I was kidding about the shaming thing earlier. The goal is to try to enable people with information so they can make an educated decision and then try it, see how it goes. If it doesn't work and something else comes up, then we've gotten one step closer. It's not a one-step process, but it's just like the other aspect isn't just like their personal responsibility. The other aspect is they have so many choices now. I mean, literally, there's so much information out there
Right.
now. How do you reckon that?
Well, and I do this a lot. It's like, hey, let's take a step back. I just kind of like try to pull people back away from all the noise. And then that's why the whole course that we do, because it's a course, it's called the Foundations of Metabolic Wellness. So literally, if you're not checking these foundational boxes, you have no business going on a fad diet or, you know, doing a Prolon. And I think that Prolon has its place. I don't mean to call it out by any means, but you just have no
Explain what colon is
business.
to people that don't know.
Fasting mimicking diet. It's a fasting mimicking diet that sends your body into a fasting state to help to burn fat and basically turns on cell cleaning, autophagy. And so it's a box that has 5 days worth of food. It's restricted calorie. Actually, it's really helpful for people who are super stressed. But again, if you have reactive hypoglycemia, you're going to feel like crap on it, and your cortisol levels are going to be all over the place.
So just to reiterate that, you're saying, and this is what I ever want everybody to hear, if you're one of those people that doesn't get very hungry, maybe you tend to eat like a bird, you tend to eat generally healthy, like fruit for breakfast, or like maybe coffee, a pastry, whole grains, something like really light. You're not eating a lot. You tend to not eat a ton. You might be even on the thinner side. And so you're not really worried about your weight. But then like you get hangry and your mood goes south when you don't get really hungry, but you get angry or frustrated. Your memory starts to go, your vision starts to go, you might get dizzy. Anything that starts to happen that isn't just hunger and then you eat and feel better means that your blood sugar's caved out, and congratulations, you just implemented a stress chemistry. That's why you're not hungry, because your adrenals have kicked
Right.
in, right? And
Yeah.
so like that person will do terrible and they'll tell you. And I
Yeah.
have such respect for people that keep trying. They're just gonna keep trying to diet. And the
Right.
diet they're doing is unfortunately moving them away from where they want to go. And this program is a program that captures that group and also captures the group that actually fasting the prolon might actually benefit, right? So tell me
Yeah.
so we're kind of hammering this reactive hypoglycemia thing, which basically leads to stress chemistry, accelerated aging, neurodegeneration, joint degeneration, leaky gut, weight gain if you have the genes for that, weight loss if you have the genes for that. Okay, fine, not a good thing. But for people why is Prolon working for so many people? And tell me who's going to benefit most from that.
I think the people that Prolon works for are the people who for me, I've prepared them for it, right? Like we are eating regularly throughout the day. We are making sure that you are eating lunch. Oh my God, everybody skips lunch. It's crazy. Eating lunch every single day. I say when the sun is the highest, that's the most enzyme activity. And I think in Ayurveda, that's what they say. But you're producing more of your pancreatic enzymes after you've been going during the day. Like you're awake, you're up, you're moving. So eat lunch, eat lunch, eat lunch. Making sure people have adequate protein. They're eating it every 3 to 4 hours. We differentiate between snacking and grazing. Grazing is eating like a bird, right? You can have snacks, but it needs to be a snack. And then you wait another 3 hours because you have to digest something completely before you can bring more food into the system. So I only recommend it, and people usually come asking for it. It's not something that I recommend a lot. Again, I'm in urogynecology, and so I'm not doing a lot of this in my the clinical practice. The group is something separate that we do. But unless people's blood sugar is more stabilized, and a lot of people are wearing CGMs now too, so continuous glucose monitors that tells them exactly what their blood sugars are on their phone. They can see when they're up and when they're down. I'm not going to recommend fasting in general to people who don't have sustained energy throughout the day.
Okay. And
but the cortisol piece, the people is good.
Do you see people with insulin resistance from metabolic syndrome and not reactive hypoglycemia?
Yeah.
Okay. So that's the person that when they're not necessarily gaining energy from food or losing dizziness from food or improving their vision or mood, but what's happening to them is they eat and they just feel really tired after they eat. They might be producing more mucus after they eat. And
yeah, they're overeating. I mean, they're going long periods of time without eating, and then when they do eat, they're overeating. And then we talk about capacity, input and outputs. Like if you overeat, if you eat beyond the capacity of what your body has to metabolize and more than what your cells need, that glucose and that insulin, they just hang out in the bloodstream and you're going to be exhausted. So it's about finding that right. Again, let's back up a second. I really focus on nervous system regulation with everybody I work with. We focus on the stress management piece and the word overwhelm a lot. The word overwhelm or the feeling of overwhelm, people want to call it anxiety, decision fatigue. Addressing this specifically helps people actually implement dietary change and then also be able to listen to their bodies to feed themselves when they are actually hungry instead of completely blowing over that signal and not overeating later, being able to feel full.
So if we're to take kind of a large angle view of this, most of the people, you're in a gyno practice. So the people that we're talking about that you're working with tend to have urinary or some sort of gynecological issue. And you're saying that you're starting them out with like a group session about metabolic syndrome?
No. So people will come in and I assess people for prolapse too, like pelvic organ prolapse and stress incontinence. But most people have, if they have recurrent UTI, or if they have atrophic vaginitis, or, whether there's all different kinds of vaginitis, AV, like you were saying, VV. It is a gut, bladder, vagina microbiome issue. And this is something I talk about all the time. There's
GBV.
plenty of, what?
It's a GBV issue.
GBV issue.
Yeah, it's a GBV.
And so in every single visit, I'm talking about an anti-inflammatory diet or gut health. We're talking about microbial balance with every single person in that context.
Yeah,
not really. I don't really into that. I mean, we're talking about fundamental stuff. I mean,
what's fundamental?
One of the reasons I chose, pardon?
What's fundamental? What do you mean?
Like eating regular meals throughout the day, not having artificial sweeteners in your diet, drinking water instead of diet soda, or these diet green teas, like the Arizona green teas with artificial sweeteners in them. People are like, "Oh, diet green tea."
What about kombucha?
What?
What about kombucha? Does that have that kind of green tea in it? Do you know? Isn't kombucha like green tea and black tea sometimes? Do you know anything about kombucha? Do you have a feeling about kombucha?
I do a little. So kombucha is meant to be consumed in an ounce or 2 ounces at a time. People are drinking big bottles of kombucha, right? It's still sugar.
I got my kombucha right here.
How much you drinking?
No, I'm just kidding.
Okay.
I gotta have a big. Yeah, there you go. There's your kombucha.
This is for my microbiome.
Okay.
Meanwhile, I have yeast growing everywhere in my body. These fermented foods are meant to be like an accoutrement or just some, just an addition to your meal. They're not
Are you
meant to
speaking
be.
French now?
Oui,
Wow.
oui.
Wow.
Maybe bien sûr.
Wow.
Right, you're super impressed. I know like maybe 20 words in France. I lived in France briefly. I was a Segway tour guide. So
You
I
did
got to.
Segway tour guiding?
We were part of the very first Segway tour. We were the first Segway tour in Paris.
Do you
So,
have a picture of you on that? Maybe that could be the thumbnail for this.
if you can find, so the New York Times came out on the ride and they did an interview. And so there's a picture of the New York Times travel section of my tour. My name is mentioned because I was interviewed from 2003. Fall
Wow.
2003.
Where
Yeah.
at in France?
Paris.
Oh, okay.
Yeah. So, back to kombucha. But okay, so just to be clear, the metabolic wellness program, this organization has allowed me to come on. I feel like who let me in? Like, oh my God, did they know?
Who did it? What do you think?
Do what?
Do they know about the Segway thing? Is this going to ruin your chances now?
Yeah, let's not air this.
What
Let's
about
not
that yeast
show
overthrow?
anyone I work with
That
this.
could be real. The whole drinking all that kombucha.
Yeah, that should be it. Yeah, with the
Okay.
caption for sure. But I felt really passionate. They were building a women's center in our city, and I live in Olympia, Washington, and it's a small enough city where you can make an impact if you just get people together. And I had been doing assisting in surgeries at this small hospital, and in between surgeries, I would be in the physician's lounge. And I'm not a physician; I'm a PA, but they let the PAs in the physician lounge.
Whoa. You're not a doctor?
Not a doctor.
All right, we should probably wrap this up. Okay.
Okay.
So
Later.
tell people the difference. A lot of people don't get this whole PA thing.
Okay.
Just explain it to them, will you?
Yeah,
Explain it to me.
The role is called a physician assistant, and they've actually changed the name to physician associate in lots of states. So yeah, because it's misleading to patients. Patients think, oh, I want to see the doctor. I don't want to see the doctor's assistant. But physician assistants, it's a separate medical training program. It's like abbreviated, right? It's like you take 4 years of medical school and put it in 1 year of didactic training, and 2 years of didactic training in medical school into 1
What's
year.
didactic mean?
So where you're just sitting in class and you're just learning. You're just learning all the diseases, you're learning all of the treatments, you're learning all the chemistry and the pharmacology and everything. So you do that for my program is 15 months, and then we go out on rotation for a year. In medical school, you do 2 years of academic training and then 2 years of clinical. So we get about half, but it's so intense. It's just so intense. And then we can go into any specialty we want. Physicians have to, once they graduate, they have to pick a residency. So they either pick family medicine or surgery or, endocrinology. They want to specialize.
Right, and you did the surgery one for a while you're waiting for this opportunity. But you have to be with an MD, right? It can't be a naturopath or
you are supervised
you
by
couldn't
an
be my physician associate, could you?
I couldn't. No, it has to be an MD or DO. Yeah.
I'm just not a real doctor, so.
Right. And naturopath can't do it either, unfortunately.
Couple of doctors here having a real conversation about metabolic syndrome. But anyway.
So we can diagnose, treat, perform procedures. I do lots of minor procedures, and then we assist in surgery. So that's something that I do as well.
You prescribe?
Pardon?
You prescribe?
I can prescribe. Yep.
You're prescribing the hormone cream a lot, it sounds like, for vaginal dryness. Are you on the Ozempic craze? Like, are you on this train?
Mm-mm.
What's your opinion on Ozempic? What do you think about it?
So I've been listening to a lot of different people talk about it. And I think a lot of smart people are doing their due diligence instead of like coming out and saying no or yes. I think they're like, let me stay curious, let me learn. But what I'm hearing, and I have a lot of patients who are on it. I don't prescribe it.
Is it causing problems with your patients? Do you have to go, hey, this might be the problem for your bladder?
No, I don't. There are other diabetes medications that cause a lot of problems. The SGLT2 inhibitors. Those just dump a ton. They put all the glucose out of the urine, out of the blood, and they dump through the kidneys, and so it goes into the urine. So
you know the brand name of that?
Jardiance, Farxiga.
Oh, okay.
Yeah, there are a couple.
So those are
But
kind of the
they,
bladder symptoms in a lot of people.
oh my God, well, it's actually more, the worst thing that they cause is yeast vulvitis. It's horrible.
Oh my
I-
God. That
It's
sounds
horrible.
terrible. Yeast
It,
vulvitis. Vulva?
it's so bad. So the urine comes out and it's just full of sugar. And they're, we have diabetic patients who already have like urinary frequency and urgency, and they have some urgent incontinence, so they might be leaking a little bit. So now they're leaking, and what the urine they're leaking is just so sugary, and so it just macerates the tissue. Like their vulvas are so red and
Oh, God.
angry, and it takes months to kind of get things under control. And I can't pull them off the medication. So I'm like, you have to go back to your primary care. You have to talk about getting off this medication, because it's amazing at pulling down the glucose and dropping
You do.
A1C.
I mean, people with diabetes, what do you tell them?
Well, I take that moment right there. We're doing counseling. I'm like, we got to get your diabetes under better control.
I could almost picture what's going on in the vulva. Like I picture a French cafe in Paris with a couple of yeasts sitting at the table, and they're like, "Oui, I will dine on this
Oh
evening."
my God, you're so funny.
It's like the perfect storm to have a yeast problem.
Yeah, it's
And
perfect.
so, but it must say that on the label, right? So like medical doctors are
It
prescribing.
does. And this is the thing. When I learned this in PA school, when we're doing pharmacology, this is the number one side effect of this medication. They're like, and I think I had a women's health expert teaching us this too. She must have been teaching this lecture, because she was like, I see this, keep an eye out for it. So it's always been on my radar. But when I get patients in with this, I'm like, they have been going to their primary care who prescribed this medication, and they're getting prescribed all these creams.
What kind of
And
cream? Huh.
like ketoconazole and steroids, and then they get prescribed oral antifungals, but no one's ever addressing the root cause at all. One of my mentors, I did a 3-year functional medicine fellowship with Evan Hirsch, who's a functional medicine doctor, and he would always use the nail in the foot analogy. It's like you go in, you have pain in your foot, and okay, we're going to give you medication to take care of the pain. Okay, and then that didn't work. Well, we're going to give you a cream. Okay, well, we're going to go to surgery, or we're going to do injections. Then we're going to go to surgery. And like, oh my gosh, we just need to turn the foot over, and there's a nail in the foot. Oh my God, just take the nail out of the foot. So that's, I really believe, like, just pay attention. You have to ask questions, and you have to look at the whole med list. You have to be thorough. And
You're a good woman at thorough, sounds like.
I think I am. I get that
You
feedback
can
a
say,
lot.
take off your shorts. You even get to say the whole thing from the Big Lebowski, like, take off your shorts, miss. Just like in the Big Lebowski,
Right, take off your shorts.
Big
Yeah.
Lebowski.
I use a lot of movie quotes.
Take
I
off your
use
shorts.
Well, fortunately for me, when I'm asking people to undress from the waist down, they're there for they know what they're there for.
Right, but still, you get to say
Yeah.
it. Now,
Yeah, I
if I
do.
could say that, you'd be like thinking about that.
I will be, and it might
Eagles
come
playing? You ever play the Eagles?
up. I hate the Eagles, man. But I'll be in the operating room, because I have to hold retractors for like a really long time. We do a lot of vaginal surgery, and I'll just, somebody will say something, I'll be like, oh yeah, and then I'll say a quote. It'll sound like a quote from the Big Lebowski, because it's the movie that I can quote the most, and nobody knows. Nobody
I
knows.
love that movie. It's so great.
Ah.
It was great inspiration for this podcast. I mean, the thing is it's very serious out there. All right. It's a very serious thing. Your health and vitality is very serious. But there's a lot of things that if we can laugh about them, that might give us an opportunity to have a discussion about how to fix the problem. But if we're so
Yeah.
serious about everything and being emotionally triggered by everything, we might not even be in a state of being able to receive the information. So
Yeah.
that's cool. I'm glad that you're into this and joking around a little bit, because it is. I mean, look, how often do I get to interview somebody that's literally in the trenches like you are? You're just in the trenches working in gyno,
I am in the
you're
trenches.
literally in the trenches. So it's just like such a great opportunity. But, if it's just so serious, and that's all it is, and sometimes that's a bit hard, so it's nice to have a different angle to approach this. So if we go back to, because we're going off on tangents here a little bit. Tell me what it would be like for somebody from start to finish in this metabolic program. I just want to hear what that's going to sound like. What would that
Yeah.
look like?
I work with 3 primary care providers who kind of keep a running list of people that might be interested in this. People that they're asking more, but these primary care providers don't have time to offer, to just spend more time education, and they say to me too, they're just not trained in they're not trained in it, right? Like primary care providers aren't trained in this stuff. So they get referred in, and the first thing that they do is go get all their labs, and it's an extensive lab panel. And then I meet with them for one-on-one. We spend an hour going over their labs, and I get them started on some basic supplements and just introduce them to some, if necessary, and then introduce them to some of these concepts, just so that on the first day they're not just so that they know what to expect.
Gut, bladder, vagina, those concepts.
Pardon?
The gut, bladder, vagina concepts.
No, these are going to be your metabolic wellness people. These are going to be,
okay.
Yeah, the foundations of metabolic wellness. We're talking about, just nutrition and gut health, nervous system regulation, sleep, movement and muscle building. I just want people to
This all just went completely over my head. So what you're saying, so you have a practice where you see urogynecological cases, and the people that you're putting into this program are not those cases. This is a separate thing going on inside the hospital.
Yeah. Sorry if I didn't make that clear.
Okay, cool. So does that mean that every woman that is it just for women? So every woman that's a part of this Cleveland clinic up in your area may get an opportunity to be part of this. Anybody that's a patient, so who is in this program?
So our clinic has one side. It's women's integrated primary care, not integrative, but integrated, meaning that the primary care clinic has access to the GI and the urogynecology and the cardiology departments. So we all work closely together. Like I said, it's a small enough hospital system where we can all communicate. We're on the other side of the clinic with urology. We're urogynecology. So I just am, because of proximity, I have a job as a urogynecology PA, and then I'm also building the metabolic wellness program.
I got you. Okay.
So I work with two supervising. What?
Holy shit.
It's a lot. And I have two awesome kids, and try to go play in the mountains and stuff.
Yeah, okay.
But
you said you were up at what, 5:30 this morning before we got on the call here?
Yes.
I was thinking about it. I was actually up at around 5:25. I wasn't 6. It was 5:25. But anyway, so you were saying
so it's a unique opportunity. I've been told, like, you're gonna have to choose one way or the other, because both of them are growing and getting really busy. And
would you let go of one to have the other? Would you just want to focus on one?
I think I'm gonna I have to do the metabolic stuff, because I can train a urogyn PA to come in and do what I do. But I was talking to even my supervising physician, the surgeon I work with. She's wonderful, wonderful human being. She's like, she said specifically, I don't want to lose your functional medicine perspective in our urogyn clinic.
That's super cool.
Listen, but I teach.
That is in a facility like that.
Yes,
That's
do.
I mean, it's unheard of.
I know. I'm so grateful. I can't even tell you. I meet with the president of the hospital, and they want to scale the community medicine program. I mean,
I'm sure it's because you're there. I'm sure that you inspired that. It wasn't functional medicine. It was you. You just happened to be the instrument, and you inspired that. That is freaking awesome.
Yeah, I'm grateful to be an instrument. So, so the women come in, they get their labs done. They come in and they do their body composition test. We have an N-body that'll measure their skeletal mass and their fat mass, their visceral fat, basal metabolic rate. And so everybody gets the baseline at week 1, and then they get one of those at week 6, and they get one at week 12. And then
is that special scan where they lie on the table and they like scan them? It was in that Netflix documentary about twins. Did you see that one where they're losing?
I didn't see it, but there are lots of different ways to do this. It's based on bioimpedance, and I don't.
You do BIA. That's what I do in my clinic.
Yeah. So we used to do it with a little machine, huh?
Yeah, BIA is awesome. I love that. It's the best way, I think. But my understanding of BIA is that it doesn't give you the deep visceral fat. That's what's missing. I would love to get that little aspect. And there was a scanner. Do you guys have that?
We have it.
On BIA?
Mm-hmm.
Wait.
We have the BIA scanner, and it measures visceral fat.
No kidding. Mine doesn't.
So it's one of our data points.
Wow. So BIA, for everybody. It's this thing where it takes your gender, your height, your weight, your activity level, at least mine does. And then I run this battery through you. You don't feel it, but it gives me something called resistance, which is your body's ability to transmit electricity, and reactance, which is your body to store a charge. And then we put that in this formula, beep, boop, 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 beep. And then boom, it spits out your body fat, your water, the amount of water inside the cell, which is where it's supposed to be. Outside the cell is a sign of toxicity. It's kind of like bloating or edema. And then it gives a number that's your lean body mass, like your actual skeletal muscle mass, your bone mass, and something called a phase angle, which is a longevity marker. So they did studies with people that had chemotherapy for cancer, and the people that had the higher phase angle survived. And so it's like in the world of geroscience and anti-aging, understanding your longevity capacity or your resiliency is huge. And so generally you want to have a good lean body mass. You want to have a good amount of bone. You don't want to have too much body fat. I think for women, it's like 22 to 32%.
22 to 25 really is what we want.
Okay, cool. And then the phase angle, if that's low, that's like if you see somebody's phase angle drop, that's like a drop your pen moment, like, okay, something serious is going on unless there was an error. So like
Yeah.
if you put like lotions on or stuff, that can mess it up. But that's really cool. I think I only know one other clinic. I mean, I know that's done a lot, okay, but like you're the only mainstream clinic I know that's doing BIA. That's freaking awesome.
Well, and you know what was amazing was they already had the InBody machine before I got there. They knew the value in it, and I didn't have to show up and be like, hey, we really need this super expensive machine. Can we get it? It was already there. It's such a gift. So measuring that and showing people like I'm like half of your body is fat mass. You know, that's happening. I'm seeing
That's
people
freaky.
with,
No, it's true. Like you do these BIAs and people, you're like, holy crap. Like I saw like 60% fat mass or more. And I'm like, we have so much work cut out for us here, because it's like once those fat cells start to break open, they release all the stuff that's been stored in there. It's not just fat. It's releasing like glyphosate that you're storing. It's
yeah,
releasing
chemicals, toxins,
anything you're
hormones.
holding on to. So like a lot of the endocrine disruptors that we're exposed to, like these synthetic chemicals, go into our fat tissue, and then we release them. And here's the problem: we release them and some of them get excreted, but if you have acute inflammation, they don't. And then it gets restored in fat tissue. Well, the brain is 60% fat. So now all of a sudden people are getting anxious and depressed while they're going through weight loss, and nobody's accounting for the toxicity. And I imagine that's some of the supplements that you're supporting with. Is stuff to help with that, right?
And just talking, like managing their expectations about the process. Like if they start an anti-inflammatory diet, that day 4 through 7, there's major fat loss happening and they are just dumping. And so helping with, gentle sweating and lymphatic, like just encouraging lymphatic drainage. And I do this detox bath. It's like 2 cups of Epsom salt, a cup of baking soda, and half a cup of peroxide. It's a trick I learned for detox years ago.
You're doing sponge
just
bath
like you can
with clients with them? They come
What?
in and they do.
Yeah, it's a special service. It's a special service.
Wow.
No, no sponge bath for
I wish,
clarity.
when are they gonna open this
Um,
cement? When's that gonna happen up there? Is that a
Oh, I
thing?
know. We have a wonderful women's spa
Yeah.
up here, and the women often go like, "Oh, I'm going to the spa for the day," and it's you pay a day pass, and it's just amazing. And all the men are like, "Oh no, why don't we have a spa for us?" So yeah, you should open one, Dr. Joe. You should open
A
one.
spa for men?
Yeah, be great. You have the InBody there at the front.
I'll do that. I think I'll do that in my
You
spare
could
time.
serve White
I'm gonna put
Russians
that
at the
spa
front,
going.
but you'd have to be non-alcoholic and dairy-free. That's how you do that.
Well, that's the thing. Like, we're kind of the middle of the day here. I'm not much of a drinker. I think what's missing is a White Russian, though. If we were going to be more official, a
And
Caucasian.
how would we make that like paleo? How would you make a paleo White Russian? I have raw goat milk in the fridge. Do have that.
Well,
But then
I did. I had an experience this last summer with a psychedelic substance, where since then I just haven't really wanted alcohol. It's been pretty good, actually. Not that I was drinking in excess, but I think that I had a heart opening experience with San Pedro with some help of a guide, and it was pretty amazing. the integration from that. And for whatever reason, alcohol just isn't as prevalent anymore. I'm not abstaining completely, but yeah, it's definitely not so high anymore. But like that was the thing when I thought about making this podcast. I'm like, oh, wouldn't that be cool to serve White Russians during the podcast? I think you could make a Caucasian with oat milk, I'm sure. I mean, oat milk is pretty darn good, you know.
No, raw goat milk.
It's the whole vodka and Kahlua thing.
Goat milk.
Goat milk.
Yeah, not oat milk. Not for me. It's
Goat
a grain. Oats are terrible for you in general. I mean,
Come on, be serious. Nobody's having milk. Come on.
huh?
Goat milk?
Goat milk. Raw goat milk.
Oh, raw. Oh, well, in that case, sure. I mean, it's raw.
Not that pasteurized shit. Excuse me. Oh, we can't say bad words. Can we say bad words?
You can swear, it's fine, whatever.
Um,
But listen, you don't want the pasteurization people after you. I already know that I'm going to get a letter from the sweetener people. So
we're gonna get from the SGLT2 companies, the sweetener people. But you know,
like
there
that's
are
like
people
your opinion, man. You know.
I hope people get all these references, these Big Lebowski references.
Well, maybe they will, maybe they won't, you know.
There's so many. But here's something that's really valuable. One of the things that we do is the patient-reported outcome measures. So they're circling at the beginning. They're doing the metabolic assessment questionnaire, and then we score them at the beginning. We score them at the end. And not only are they decreasing their fat mass, which we can measure, right? Because a lot of people get really hung up on the number on the scale, right? I want to know how much fat you're losing. I want to know how much muscle you're putting on.
That's the BIA. That's what the BIA is doing.
Yeah, right. Yeah, the body composition. I care about your body composition.
Thank you.
Because you can lose. Oh my God, there's so many things to talk about. That's the problem with Ozempic. We never got back to that. Is that people are they're finding that people are losing skeletal muscle mass.
That's ridiculous to me. Come on, man. Like, why don't we just accept that the anti-aging industry of hormone replacement, of external only stuff, okay, is not anti-aging medicine. It's trying to look better. And a person can be rotting from the inside out while they're looking better. And there is absolutely benefits to losing weight, 100%. If a person's obese, losing body fat could extend their life and their quality of life significantly, okay? But nobody's asking the question, why do I need Ozempic other than I'm obese? And that's the problem with medications, is like, they are freaking amazing. It's amazing what medications have offered people, right? I mean, come on.
Yep.
But if you don't understand why you needed it and you don't address those factors, if it's not just simply overeating and you're not doing things to account for the disruptions in your physiology this is causing, then there is a strong potential to do harm. And nobody's talking about it. Nobody cares. They're like, I'll deal with that later. But they don't, unfortunately, I don't think people are getting the full story. They're not getting what happens when I have to deal with it later. They're not understanding some of the neurological issues that are coming up. They're not understanding some of the autoimmune issues that are coming up. They're not understanding sarcopenia and its connection to things, which is muscle mass loss, and its connection to things like dementia. They're just saying, I want to fit into my whatever. And that's fine. It's fine. But what about informed consent? Come on.
People are, but you know what, Joe? People are overwhelmed. I mean, this is the thing. You know,
it's not the people. I think it's the medical model. I'm sorry. We need to inform them. Informed consent.
Yeah.
They're not getting it. That's what I'm saying. Of course, they're going to make that choice if they're just told it's that easy. How many women at the age of 9 are being put on the pill? Girls, their first period, they're getting put on the pill. Is there informed consent? Well, yeah. If you look at that giant accordion thing that the pill comes with, yes, heart attack, stroke. You know, it's like, okay, well, that's not me. Okay, well, what's the number one cause of death? It's up there. Heart attack and stroke. Okay, we got heart attack, stroke, cancer. They're all up there. And so they're saying, oh, the pill didn't affect me. Did it? Or is it just you're unlucky? Do you know what I mean? It's crazy. So informed consent should be more than giving them something that they're not going to read. I mean, did you ever take birth control?
For about 3 weeks in college.
And what did it come with a very long?
Oh yeah, it's so thick, and it's
Yeah.
like, there's an adhesive in there that you pop open and it just like comes out.
I've seen a couple of those. They bring them in, and the only thing I've seen longer is like a Walgreens receipt. That's the only thing that could be longer than that. I mean,
Right.
you could stretch that to the moon and back. I mean, that's
Right.
how big that is. So who's going to
Yeah.
read that? Honestly.
Right. Well, I will say that it's happening. I mean, there is so much information now, and there are so many women who are like, I'm done with this. And younger women are asking more questions because
Okay.
they're getting sicker earlier. There's this I mean, I'm seeing this. Women in their 20s and 30s are way sicker than they've ever been. We're seeing autoimmune present way earlier than it ever did.
This is happening on our watch.
What?
This is happening on our watch.
Well, there are only so many of us. I mean, that's the thing.
I
So
know
here's the solution.
It's so sad because it's never better time to be in practice. There's never been more information available. We've never had we can talk about this if we have time, but the different tools that are available to us with AI as clinicians to help nail that mechanism for them, like more specifically, like a high pixelated view, and that information just like this, instead of hours and hours and hours at seminars, we can get information like this.
Okay, two things. That doesn't solve the problem of people's nervous system dysregulation and trauma. People are wired for fight flight. Like we can provide their supplements and we can give them these protocols and we can get to the root cause, but it is the heart work. And that's why community medicine is beneficial, because people can be in a safe space. They can pull out of that fight flight, that cortisol dominance. But that is the real work. I mean, having compassion for people, allowing people to say their most vulnerable things and helping them rewire, like let's talk about that. And the other thing is training clinicians. I mean, this is, I've gone to the, I submitted a proposal to our president of the hospital, and I was like, I would like to train all of the clinicians in the primary care to look at labs the way that I do, but not from an arrogant place, not from a like, this is my way is better. It's like, hey, this is what works, and this is what I'm hearing. Hey, I don't know how to interpret these labs, Allison. Why are you ordering these labs, Allison? And so they are willing for us to spend more time on lifestyle medicine and functional medicine training for these clinicians, so that they don't have to go and spend tens of thousands of dollars on conferences and trainings and certification programs.
I know.
It's inaccessible,
more money
right?
on seminars than I ever did in chiropractic school.
Oh, well,
so much.
I'm still paying off my student loans for PA school, but yes, thousands and thousands and thousands of dollars of training outside our medical school training. And this is what I have to tell patients, because they say things to me all the time, like, why did no one ever tell me this? How come no one ever asked me the questions you're asking me? I'm like, well, there's not training. There's not time to train for that in school.
You ever get shit from somebody because you're a PA and they're like, oh, well, my doctor didn't tell me this, so.
No, never.
That's nice. I don't wear like my Tommy Bahama shirt and stuff, like at work, because I'm a chiropractor and that's cliche. I stick for that at home. But like, even though I don't wear my Tommy Bahama shirt and my pleated khakis and have like chest hair coming out here, people still will ask me, well, if it's true, then why hasn't my doctor told me that? I mean, I told my real doctor what you said, and they just basically said, you're an idiot.
Well, I think that's
you don't run into that? Is it just me? It's okay.
This is why I chose PA. So I was going to go to naturopathic medical school. I had a mission when I had a nutrition practice. I was a nutritional therapy practitioner where I learned 70 to 80% of this, or at least the foundational stuff. As a nutritionist, I'm using the stuff that I use as a nutritionist in clinic every day, and that's the stuff that helps reverse people's chronic illness. But I was on a mission. I was like, I want to go into primary care, and I want to integrate lifestyle medicine as primary care. And so, well, how do I do that?
You wanted to change the industry.
Pardon?
You wanted to change the industry.
I wanted to change the industry.
Well, that's pretty ambitious, don't you think?
Yes. And I keep getting told, oh my gosh. Anyway, so it was either go to naturopathic medical school or go to become a PA.
What were you being told? Tell us, what were you being told?
Oh, in PA school, we'd talk about rheumatology. It's a rheumatology lecture. And Doctor, Dr. So-and-so, I remember who it was, but why don't we just support their immune systems? Literally, we don't do that. That's what he said. He's like, oh, we don't do that. That's not what we do. Like, well, who's doing
No,
it?
that's not what we do. That's
That's
the
not what
answer.
we do.
Because our model does not do that. That's why.
Right.
Because
Right.
isn't that interesting? So we're talking about high level academic institutions, and I run into this quite often. I have run into this quite often over the years, and like working with clients that have medical doctors on their team, co-managing them, and like we need everybody rowing in the same direction, and it's difficult for us all because there's unfortunately you have these competing paradigms of how to do things, right? And it's like the number one answer is because we do it this way, because we said so. And I'm like, you're talking about like people from like Ivy League institutions and like top medical degrees in the Bay Area and all over the world, and they're like, because this is the way we do things. And I'm like, well, how's that working out? And
Well,
that doesn't seem to matter. How it's working out is less important at times, it feels like, than being open to trying something outside of what's done every day, to see if we can help the people that are slipping through the cracks that isn't responding to.
yeah.
That's how I got into what I do, not because I loved spending all of my weekends early on. I used to not like education as much. I liked mountain biking and screwing off basically on my free time. But I got to the point where I saw all these people in my practice as an intern that were not being helped by medical doctors. They weren't being helped by multiple chiropractors. They weren't being helped by acupuncture. They weren't being helped by naturopath, by PAs, by massage therapists, by gurus, by swamis. It didn't matter. They were slipping through the cracks, and they were running into a problem where they had too much complexity for one paradigm to meet all of their needs. And I wanted to help that person. And it's just like, it's just surprising to me how still, 20 years into this thing, how hard it is to appeal what seems like to what's obvious, to reason. But if your paradigm won't let you see something, then it won't let you see it. And that's the strength of their training, I feel, is you're trained to see things a certain way. And that's the beauty of going to a particular type of doctor in the medical model, is you're going to get a well-trained doctor. They're not going to miss the things they're trained to see, and they're not going to waste their time with the things they're not trained to see. In some ways, we're asking too much out of doctors to be open-minded, but it is fascinating. The number one question is, why don't my doctors say this stuff? And I think it's so cool that you're in the model, inside of the model. I think it's brilliant. Like if I ever could go back to school and do differently, I might do NP so that I could be inside the model instead of trying to be a revolutionary outside the model, seen as an outsider. I'd like it to be more inclusive and try to create change within. And I think it's beautiful what you're doing. I think it's
Thank
tremendous.
you. Thanks.
It's a tremendous challenge, and it's very ambitious. And I'm glad that you've gotten to the point where people, instead of saying, because we do it this way, they're saying, what is it that you do? Wow, that's phenomenal. We'd like to include that in our clinic. Can you head that up for us? That's a shift. And that's like something that if they can do it there, then it can be done other places. And like
That's
basically
right.
what you're doing is you're trailblazing something that could be a new standard of care. It's not a small thing. And
Yeah.
I'm
Wait. I mean, that's the hope. That is really the hope. And I have a team, and leadership who believe in it, and they want to see that happen. They would love to see that happen. Right now, there's just not enough there's not enough hours in the day to do
not
it
enough.
all.
There's not enough people doing it, but you got to start somewhere,
Yeah.
and it's wonderful.
Yeah.
So,
Thank you.
okay, so they come in, they're in this program, they do some diagnostics with you, including the body composition assessment, they do a questionnaire, they do some labs. Tell me a little bit more about the labs that you run as a baseline with people.
So one thing that gets missed and a lot of people don't run generally is insulin. And so like, gosh, if we just ran insulin on everybody, we'd catch way more prediabetes. So prediabetes screening is pretty weak, especially if they're just checking like a glucose and an A1C. Then you could have a normal A1C for a really, really long time with just running around with high fasting insulin all the time. So that's we do that basic CBC, iron, ferritin.
Do you do C-peptide at all?
No, I used to. So we used to use that different functional labs. So we're just using like standard, LabCorp or Quest Labs, just whatever's commercially available, in our town. Like some of the hospitals have their own labs. So
Can you tell us a little bit more about what each one, because I know what those markers mean, but can you tell everybody what each one of those markers represent a little bit more? So you said glucose, hemoglobin A1C, iron, ferritin, and insulin. Tell us a little bit about each one.
yeah, and you can go into them. You can go into them more too. I mean, I used to do a lot of this, but let's see. We also do like a DHEA and inflammatory markers like hsCRP. I really like the cardiometabolic markers like ApoB, LP little a, and LPPLA2, LDLP. So let's start with the lipids and then kind of go back. So you go into your doctor, you get cholesterol, your LDL cholesterol is high, and then they recommend putting you on a statin, right? And it's like, oh my gosh.
This is like if we had like a knee-jerk response.
Yeah.
It's like you could go in with anything. You could have anything. You could go in there, you could be 25 years old wearing a diaper because your leakage is so bad. And your doctor's like, well, I don't know what to tell you, but your cholesterol's high, so we probably should get you on a statin.
Yeah.
I can do that for you. And they're like, well, but what about my leakage or my incontinence? They're like, well, could be stress, you sound a little depressed. Maybe you're depressed. And I'm like, well, yeah, I'm having incontinence. I'm 25. I'm depressed about that. I don't know what it is. Well, okay. I could write you something. Maybe we could send you to psychiatry.
Yeah. But you did something because you gave them a statin.
Well, and it's
I don't want to be critical either.
It's trying to be helpful. I'm not saying that, but anyway, so the lipids.
Yeah, and I just want to say, like, I have so much respect for my colleagues. I think that everyone who gets into medicine, I think most people want to serve and they want to do the right thing. They really do. I think that a lack of knowledge, and then I think a fear of being wrong, or getting out of your lane. I think that's really what prevents people from being more curious and doing more for patients. That and the time constraint.
Well, that's very, very nice of you to say that. I know that you believe that too. And of course, I'm not just shitting on doctors. Okay.
I know you're not. No,
but it could sound like it. So I'm glad that you said that, because I do have respect for doctors that have sat down and dedicated their life to helping others. And I do feel that there are a number of people that the existing models are not serving. And so, like, with that in mind, though, like,
I think a model is the one to go after, right?
What's some of the craziest stuff you've heard doctors say to patients?
Well,
not just medical doctors. Like, let's say this. What's some of the craziest advice you've ever heard one of your clients get?
Craziest advice?
Or like, what's some of the experiences that your patients share with you?
I
oh my God, this is so great.
When people get told that it's all in their heads, I'm like, okay, well, let's start talking about your methylation and your COMT, and but they get told it's in your head. It's in your head. It's in your head.
Oh, it's in their head. I mean, like,
right.
I wasn't talking about that statement. I was talking about other statements about cholesterol. Let's reel it back here a little bit. Like, clearly, mainly for women, it's in their head, right?
Right. We're all crazy.
Well, there's that crazy hot matrix thing.
Right. No.
Hot matrix? Really?
No.
Oh yeah. Check out that YouTube video. It's hilarious. The crazy hot matrix. Yeah.
Not
all women are crazy, but there is a crazy hot matrix.
Well, I'll have to look that up. So I think that's the biggest thing. The craziest things that I've seen, I can't really share, right?
You can't tell me their names.
Yeah, I know, but I don't know. I just
first, last name, social security number, address, primary phone number. Nobody else is watching this. We're good.
Lipids. Let's talk about lipids. I'm gonna, So if you have high cholesterol, you want to get an LDLP. I want to know the particle number. I don't want to know just the concentration of low density lipoproteins, the bad cholesterol. I want to know what your number is, and I want to know the quality. If they're large and fluffy, if they're small and dense and sticky, that's not good. You want large, fluffy cholesterol. We could go into
talking about HDL. Or are you talking about even your LDL?
LDL. Still talking about LDL. Okay. So LDL is this number. You get one marker, right? LDL-C. But then there's this whole story that needs to be told about that number that can determine whether or not you need a statin or actually what kind of lifestyle intervention you need. ApoB is the number one marker for assessing cardiovascular risk. This is a protein that's on the cholesterol, a lipoprotein, that when it's elevated, it's going to increase your cardiovascular risk by causing inflammation in the blood vessels. LP little a is, and I know you use this one a lot because it's a marker for neuroinflammation too.
Super
So,
huge in dementia. Let's face it, a lot of people have the genes for this.
yeah.
Genomind is a good test to do these ApoB genetic tests. If you have this genetic predisposition and this is elevated, basically you are fast tracking your way to significant medical expense of assisted living and horrible quality of life.
Yeah.
It's really the thing that I'm most passionate about these days. One of them is like helping people extend the runway so they outlive assisted living, nursing homes, and dementia. You can do it.
Yeah.
Most people can do it. There's obviously cases where there's head trauma, stuff like that. But like, just imagine this for a second. Imagine all of these boys right now on the West Coast, 1 out of 4 boys in California getting ADHD, developing ADHD as their brain isn't developing, and their frontal lobe never fully develops. What's going to happen to these boys as their brain starts to degenerate?
Right.
Okay, we're looking at ADHD. When does ADHD become dementia? Okay, because what is it? Lack of attention, poor memory, poor cognitive function. A lot of these kids have balance issues, sensory processing issue. Do you ever notice that when people get older, they're like, what did you say? It's not always hearing. Even with the hearing aids in, they're just a little slower. Okay, their balance isn't so good. Their memory isn't so good. It's the same thing, just in reverse. And we are looking at a massive problem. And this ApoB thing, for some people, is going to either take a blowtorch to that, or if we address that properly, it may completely take that variable off the table.
And that's just knowledge. That's just your clinician in primary care just needs to know to order it. That's it. Because if it's elevated, like, okay, now we have a problem and we can address it with lifestyle. Like, let's start talking. I mean, I know that you have a much more comprehensive evaluation process for people, but for me, where I am seeing just so many patients, it's like, okay, you need to learn how to eat, period. You have to get the seed oils out. You have to eat more regularly. You have to stabilize your blood sugar levels. Because it's not just what you eat too. It's like the quality, how well your liver is functioning and the inflammation in the body. So, a marker that I would highly recommend for people to get checked is that ApoB.
What are some things that in your experience work for people to lower ApoB when it's there? Say they're having memory issues or vascular issues. So like vascular issues could be cold hands and feet, hair falling out. That's a number one cause of hair loss. One of them is like they just don't have good circulation, brain fog. So like when you see these vascular issues and you see these memory issues, like if you're a man and you look down at your leg and it looks like you're wearing a sock where your hair is off your leg where your sock normally would be, and it's not because your sock is rubbing it off, that would be another indication of a vascular issue. So like, what are some things that you really find is helpful for lowering ApoB? Because I see this a lot and I'd be interested in what your strategy has been.
Well, I think I do think that inflammation is a target. That's why we look at that high sensitivity C-reactive protein. And so that's an inflammatory marker. And if you're using high sensitivity, it's more specific to cardiovascular inflammation. So that's a great marker. Like looking at that with the ApoB, it's like a major motivating factor. Like, hey, these two numbers together with your insulin also, this is priming you for a heart attack. This is priming you from some sort of event. We've got to do something now. And I think that I love being older. I love not being 28 and saying this stuff to people anymore. I love being.
It's nice, isn't it?
Right? I'm in my 40s, like, I've got some gray hair. Like, I can say this stuff,
You don't look gray.
Yeah, I do. So I think that when I show up with my care and my attention and my sincerity, and I am never, I was made for this, I guess, because I
Sure.
can
You have an awesome personality for this particular role. Like you found your calling. Absolutely.
I'm a calling. I would like to spend less time in front of a computer. That would be, let's transition.
The next interview, season 2 or 3, when we do this, we'll do it in person.
Okay, great. Yeah. But every day, seeing patients and documenting, that's the thing. So that's where AI comes in really handy. It will. But So,
Okay.
hey, huh?
Okay, AI has been tremendous for my documentation.
Yeah, I'm so happy for you. I can't wait. We'll try it for scribing. But to reduce to bring down the ApoB and to bring down the HSCRP, I am not kidding. I know that it's not always as simple, but gosh, getting people off gluten, dairy, corn, soy, and sugar.
Hey,
And
listen, I'm offended by that.
I
My
know.
family
Don't
has a
hate me when
farm
I
that
say
grows
it.
wheat.
I say, don't be mad at me. And I say this all the time, like, don't be mad at me. I'm like typing it on there, like, please don't be mad at me, and I'm being playful with them. They're like, you just took away everything fun. They're like, what do you eat? I go, everything else, you know?
Oh.
So it's really hard and it's shocking to people's
Back to
systems.
that choice you talked about, the responsibility and the choice. Once you give people they're like, well, I didn't know that I was going to have to stop everything I love in order to feel better. Well, it's kind of cool. Once you pivot out of food being your primary joy in life, your life opens up to other things. It really can. It sounds stupid, maybe, or
No,
cliche.
that's why the whole San Pedro thing, it's like, you don't want to you don't need a drink because you are receiving the beauty in everything. Like beauty is this access point to joy, to love, and to joy, and right, and everything that we are addicted to or leaning towards is to get a dopamine hit, right? Whether it's sugar, caffeine, sex, cheese, flying down a mountain on skis or a mountain bike. It's all so that your brain can experience this hit of joy, right? And so that's what we talk about. Yeah, dopamine, right? So the work that I really, what is at the core of the work that I do, despite the labs and the counseling and the groups and the exams, whatever, the core of everything is to help people access joy so they remember what their good health is for. And if they can do that, and that's like has to be woven in, because I'm not a counselor, I'm not doing spiritual retreats with people, maybe someday. But I have to weave it in.
Do you know Jessica Flanagan? Not
No.
Flanagan now, but do you know who I'm talking about? The AIP lifestyle gal. She wrote this book.
Oh, the love diet. Yeah.
Yeah, The Loving Diet. But she wrote another book. I mean, that's the thing. That the deal is like it's not about the diet. It's about
Yeah.
finding that center. But she's also like really progressed in her field, and now she's really her whole strategy surrounds what you're talking about, which is like, if you're not in the place to receive healing, it's not going to happen. And so
And
she
that's why
a
we're
lot of
trying to
people that have done
create,
every diet under the sun, and it just doesn't work for them
right.
because they're not in this place. And I think that from my experience, you have to be in the place, but also you may actually need to do the diet too. Like
Yeah. Yeah. I mean, that's how we're doing it. You and I and all our, colleagues that we have and the company we keep. I mean, we know that you have to do it all. You have to do the heart work, the spiritual work. You have to eat a clean diet. You got to take care of your gut. I mean, you got to sweat. You got to move. You got to build muscle. These are
But
these are
clinicians, we take care of each other and ourselves. Like, what's the number one thing you do for yourself? What do you think? What's your favorite thing that you're into now that seems to really move the needle for you?
staying strong.
Staying strong. So
Yeah.
working.
Just lifting stuff. I don't go to the gym, but I have weights at home, and I'm always trying to lift heavy stuff. I kind of, the thing I say is lift heavy shit. It's like I tell women, I'm like, lift heavy shit. I don't say that in clinic, but
Swear in the clinic?
say again.
Don't swear in the clinic?
No, no, not typically. Or I'll say like, we have this product. I know you know it, cortisol manager.
Oh
We
yeah.
we call, we call it the I don't give a what pill, and that's what I say.
Pill?
Like, yeah,
Or F. I don't give an F. Bill.
yeah. That one's big. But yeah, I like to play outside. That's what I want to play as long as I can. I want to keep my muscles and my joints healthy so that I do love mountain biking. I mountain bike with my 16-year-old son. He's an excellent teacher. I like to ski.
Have you heard of
Pardon?
tonal? Have you heard of tonal? Like, I'm not attached to tonal anyway, but like one of the best ways to stay strong, because you love doing it in a very efficient way, is variable resistance training, which is like if you see people using like they're doing like a shoulder press with like bands attached to the floor, okay, that kind of thing, or chains. Like, okay, so like tonal is this device you hook to your wall. It looks like kind of a giant iPad, and then it's got these arms that come out and cables. And I've gained almost 20 pounds since the fall, and using BIA, 12 pounds of skeletal muscle.
Awesome.
Since the fall, using tonal, only working out 3 days a week.
Yeah.
It's a great way to build muscle.
Cool.
I've found a faster way to
Goes on
build
the
it.
wall.
They have
I
like,
can have it at home.
yeah, well, I have it here in my
Yeah.
office, but you can get it at home. They basically come in and install it for you. They have, deals going on all the time. They have like financing options for like the first 3 years, even, so you could get like zero financing. The only thing is like $60 a month for the courses for the first year, and then I don't do the live courses. I only do the pre-recorded anyway. But
Yeah.
it's cool, man, for people that have
I'll
a
look
place
into it.
where
I
they
need
can
some structure. You
No,
know?
it's been so awesome. I can't even tell you. And the workouts aren't even long. They're like 30 minutes or less. The ones I do.
See, I need like a 18-minute workout. But this is what I tell women. I'm like, and there's some new research that's come out that says that women need to do weights resistance training twice a week to get the same benefit that men have to do, that men can achieve with having to do 4 days. And that's just what I say. It's like, it does not take a lot, but we have to stay strong. Like, women have to stay strong, just to prevent bone loss, prevent just
Dementia.
frailty. The
Yeah,
word
early
is
aging.
frailty.
Yeah, it's great for the
Yeah.
hormones. Okay,
Yeah.
there's just a lot of benefits to having muscle mass. Of
Yeah.
course, overtraining is its own beast.
Well, that's why I say you don't have to do a lot. Like, you do not have to be a gym rat. This is great. I'm totally gonna look up tonal.
It's cool. It actually goes at your pace. I mean, like, there's a few people that have not done well with it. People that have anemia, where they don't really burn fat very well, and they have secondary hypothyroidism or primary hypothyroidism, where they're not repairing tissue very well. The thing about variable resistance training is that as you're pushing the cable, whether you're doing the deadlift or whatever it is, it adds a level of resistance as it feels where you're struggling. So it's sensitive to know where to add and let up, and that variable
Yeah, that's
resistance is
amazing.
so good for the cerebellum.
Yeah. Then
Okay?
it prevents injury too, right? You're not gonna overwork it.
You can overdo it still, but like, it's less likely,
Cool.
if you do it properly, if you follow their technique. It's really, really, really cool. And that variable resistance causes a little more damage to the muscle, and then that's how it hypertrophies and builds back. But you have to have the ability to build it back. So let's say like you have long COVID and you're making a bunch of like free radicals, you're already damaging tissue. That's probably not going to go well. If you're have a thyroid issue or a secondary thyroid issue, or systemic inflammation that's severe, it may not go well. If you have anemia and you can't burn fat successfully or get oxygen to tissue to repair, you may get like really sore and then not recover. But that's not the majority of people out there, so it can be extremely useful, especially if you're tight on time, and it's cheaper than a gym membership for a lot of
Yeah.
people.
That's awesome. That is great. Do you want to talk about those lab values, just so that we don't, people are like, when are they going to talk about
Yeah,
those?
so like, okay, so fasting glucose is just like when your body's at rest, can your blood sugar go down? And that has something to do with the amount of sugar you're eating and how much insulin and cortisol you have in your system. So it's kind of like looking at different markers there. And then you have hemoglobin A1C. So think of blood sugar as like your weather of your blood sugar. Hemoglobin A1C it's kind of like creme brulee or a baguette. Creme brulee is kind of crusty on the top. A baguette is kind of crusty on the outside. So as you have elevated sugar and insulin, the proteins embedded in the fat of every cell in our body get caramelized. And so hemoglobin A1C is a caramelization or browning of your tissue. It's a really strong biomarker that's associated with accelerated aging. And type 3 diabetes is actually Alzheimer's, is one way to call that. And it's just a high hemoglobin A1C can basically cook your brain inside your skull. And so that can be a problem. And then you have iron, which is super important. People have too much iron. I've seen a lot of hemochromatosis actually in my years in practice. And people can have not enough iron. But the thing to look out for with iron is ferritin is iron stores. So what happens if iron gets exposed to too much oxidative stress from like inflammation, or not enough glutathione or antioxidants in your lifestyle, or too much oxidative stress like smoking or overtraining, lack of sleep, too much sugar, what happens is the iron will rust in your body. and your body's like, screw this, because if my iron rusts and that gets in my brain where I'm supposed to make dopamine, it causes significant damage and can accelerate things like Parkinsonianism and things like that. Here's what that looks like before you get Parkinson's: loss of sense of smell, serious face, stiffness in the shoulders and hips that gets better when you get up and move, muscles that kind of move when they're not supposed to. Constipation is a common one. So a lot of people, shoulder problems, constipation, and like kind of like a non-emotive face actually are showing signs of Parkinson's. And the deal is if their iron is high, that's a problem. If their iron is rusting, that's a problem. But then what'll happen is the body will try to move iron out of circulation into storage, and that's ferritin. So if ferritin's elevated, the body's like, I'm acutely inflamed. Let's get this away from the bloodstream so that we don't rust. And so if ferritin is high, that means that there's acute inflammation somewhere, usually, if it's by itself. You could have normal ferritin and normal iron. If for women, generally, I don't like, especially women with the period, I don't like it when ferritin's higher than blood iron. So like if their blood iron is like kind of barely hanging in there, like the low normal is like 80 or something, and their ferritin is like 100, but it's not technically elevated. To me, it's like, well, why would somebody be low normal iron but then high ferritin? That's a sign of inflammation. Of course, they're going to have fatigue, lack of stamina, brain fog, period symptoms because of stress chemistry, insomnia, anxiety, depression, bloating, you name it. Okay, all the stuff that they run to the supermarket for to try to get over the counter stuff, or they go to the doctor for something stronger. That could be the basis of acute inflammation, which can be measured by that CRP measurement that you talked about, and ferritin. Interesting thing about CRP is when you look at CRP, it actually says underneath it in the lab reports that I get, if it's elevated, it says chance for heart attack or stroke is imminent. Imminent, if that's elevated. Imminent, meaning you will have a heart attack or stroke at some point in your life if you don't get this under control. What that freaks some people out, because it's actually appropriate to have high CRP sometimes. Let's say you have an acute infection, your body's actually trying to resolve it. So like as a doctor, you can't just put people on anti-inflammatories. If you see high CRP, you have to go, well, is it appropriate for this person to have CRP? But we all know with like long COVID, for example, and acute COVID, how it was really wrecking some people. There are people that deny that. I know even some of the people watching this are like, yeah, whatever, dude, I'm going to turn this off now. Okay. But the reality is like so many people with cardiovascular issues from long COVID, and part of the reason is because their CRP was up for a prolonged period of time and it just was shredding their blood vessels. And if they have that plus the ApoB, those are the people that are having significant neurological compromise like depression, anxiety, insomnia, in addition to everything else they're dealing with, vertigo, you name it. So I think it's really interesting that they're basically making this mainstream at your clinic, and hopefully that's something that gets replicated. Okay, so we have this assessment where they do body composition. You guys do a questionnaire, body composition. You do labs, and then you have a community. You have a kind of a heart-centered finding your healing place approach. And so then after a person enters into this program, how long are they doing these things? How long are they doing the dietary changes? How long are they taking the supplements if necessary before they come back and get their reassessment?
So we do 12 weeks of education and the intention is not to fix everything in 12 weeks. It's to learn the foundations in 12 weeks.
Phase one, basically. Okay. So the first phase is 12 weeks. And then after that, did they enter again into another program?
So that's what we're trying to figure out. Like, what's the next step? And we sent out a really nice survey, and everyone said that they really want continuing. They want a continuity of this care. They're like, well, can we just keep going with the group? Everyone wanted to keep going with the group. So that's what we're working on right now. We're working on hopefully working with an outsourcing to another company that's going to come in and help us do lots of groups so they can maintain continuity with health coaching.
There's only one of you though, so they need to train more people. So like how is this structured in terms of like, are they paying extra for this, or is it members of Cleveland Clinic?
It's getting the way that the group visits are now billed, and there are different models like in prenatal care that you have a centering program that is, this is not a brand new concept of group visits. Like it's just, so it's billed like a visit. So the way that we do medical billing and coding is like, it would be attach a number of the level of the visit to it. And
Is it
then,
covered by their insurance?
yeah,
Okay.
yeah,
So
sorry.
then how
Long
many
answer
group
to your
visits do
very
they have?
short question, huh?
Go ahead. Go ahead. Yeah.
No, we just run it through. So like I said, when they come to the front desk, if they got a copay, they pay a copay. They get billed for the visit. It's under a specialty visit because I'm providing a specialty service.
Okay.
And then they pay co-insurance if they have co-insurance with their insurance.
Okay. And so how many visits is it typically for phase 1 in 12 weeks?
They get 6 group visits
Okay.
and as many, at least 2 one-on-ones, and they can have more if they want to schedule more.
Okay. And those are a la carte and they're covered by their insurance, or are there people
Yes.
that their insurance isn't covering it? Is there any out-of-pocket expense right now at Cleveland Clinic for this?
Supplements.
Supplements. Okay. And who typically is being streamlined to this program? Could anybody in your area go to that's a member go
Not
or
yet.
this?
The pool because it's so small. It's just me. It's just one conference room, and I have 1 day a week to work on this program because I'm
Okay.
doing the other stuff. So it's just these patients are just coming in from our primary care clinic right now.
Okay.
I have a few I've pulled over from my clinic, but the goal is to. I mean, we are realizing we just sent out an email for our perimenopause group, and we sent it to everyone between the ages of 40 and 49 in the primary care clinic. And within 8 hours, we had the class filled, 12 people, and then I think 20 people on the wait list. And
Wow. Congratulations.
so
I'm so happy. This is going to be, it's just such a beautiful start, a beautiful beginning to have that kind of momentum.
yeah, thanks. And you know what's so uh rewarding, and you talked about like how people depend on the doctor too much. And what happened was the first couple visits, they were a little, shy, right? Meeting new people, were holding a little bit back. But I encouraged them. I said, it's up to you because I can't do this for you. But if you wanted to exchange phone numbers, you can connect outside of this container. And they did, and they have had this insanely supportive text thread. They all love each other. They come in, they're all chatting. It's like I just get to sit back. They include me, right? They appreciate me. But I get to sit back and watch them heal each other. And they are so, just like you said, they're supporting each other with ideas and recipes. And I found this. Have you tried the Siete tortillas? Yeah, they're anti-inflammatory almond flour tortilla, right? And they love each other. They definitely loved each other by the end. And these are women from all walks of life. I mean, everyone's got different work experience, life experience, different trauma. They have different diagnoses. And they were there for each other. They maintained connection outside of the clinic. It was really beautiful. And I was like, oh yes, this is it. But we just need more. We need more clinicians who are willing to do this work. We need to train them to be able to be coaches. We need to utilize the coaches that are out there too.
Can
The
you
group.
add a day? Could you like move away from one part of your practice and just add a little bit more of this?
Oh, that's the conversation that we're trying to figure out right now. I mean, I don't want to bore your listeners with my personal schedule, but I think the intention of the organization is that I just do this full time, and then
Okay.
we train a Urogyne PA to come in.
Okay, cool.
Yeah.
That's awesome. So this is kind of a long way though from being on a Segway in Paris. Like, how did you end up even in the field? Did you know when you were in Paris that you wanted to do this still? Like, how did this even happen for you?
This is a long story, but I'll try to make it quick. I graduated from college with an art history degree. I loved learning about where we came from, and I loved the puzzles. I loved putting all the pieces together, and I loved that I was doing that through the expression of the human experience. So it's like, oh, the way that we can understand, excuse me, what people were doing and why was really through the art and the artifacts they were leaving behind. And so I started studying nutrition, and I was always interested in healthy eating. But I started studying nutrition and wellness in college. But I had to finish a degree. I couldn't change my degree. I was really looking forward to being done. So I took a semester off between art history and what I thought was going to be a graduate program in fine art and an MBA, go work in galleries or whatever. And just became really clear that I needed to study sustainable food systems. That was what I know I needed to do. I needed to make the world a better place through healing the food system. So I was looking at graduate programs, and I found a master's in environmental studies up here in Olympia, Washington, and they were going to let me customize a sustainable food system master's program. And I moved up here, and I'm from Texas, and I was used to sunshine and dry and warm. And I moved up here, and I moved into a duplex with horrible mold. And so I went from this being this like vital, 22-year-old to very sick, very fast. I couldn't believe it. I look at pictures of myself right before I moved here. I can't even believe it. I've never been the same. So I got really
Well, not
sick.
the same. You haven't gotten some of that back, you're saying.
Yeah. Yeah. I've also aged 20 years. So
Do people believe you? Well, no, it's not about being youthful, like in an unrealistic way, but saying that that was a pivot point for you.
it
And
changed me. It changed me
people,
for sure.
there's kind of like a couple different camps on mold. One is that everybody has mold, and it's always the issue for everybody all the time. You run into those clinicians in the kind of adjunctive medical space or alternative medical doctors, naturopaths. There's a lot of that. And then there's people that are just mold deniers. Like
Yeah.
mold.
Well, I didn't know. I mean, since then I became trained in treating mold illness, but I had no idea. I mean, but I was very sick, very, very sick. And I went to the local herb store downtown, and I'm talking with this herbalist, and I'm just like crying, and she's like, "What do you?" And I was like, "I don't want to go do this master's program. I don't know why I moved up here." And she's like, "What do you want to do?" I go, "I want to do what you do." She was a healer. She was an herbalist who was a healer and a practitioner. I said, "I want to do what you do," but I said, "But with food." And so she directed me towards my nutrition degree and my certification process. And then I went to work in a lifestyle medicine program as a nutritionist with a PA who was doing what I'm doing, but 20 years ago on her own. And then,
I met her. I think I
yeah.
know.
Wait, Donna, you met her?
Oh no, I didn't meet her. I was
Oh, you
taking.
met Michelle. Yeah.
She was at that seminar, but we met it.
Yeah. Yeah. No, that was different. That was later.
Okay.
But no, I worked for PA as a nutritionist, and she said, "You should go to PA school." I was like, "Okay." So I did.
Right on.
So it was a long, windy way, but I did take a semester off, and I went to Paris, and I got really sick in Paris too. Came back, went to Arizona, but I didn't have mold. It was homesickness, and
It was what?
I don't know if it was just homesickness or the cold weather was just so hard for me. It was,
Well, just being around the French for that long,
oh my God, they're amazing. They're amazing. I had amazing meals.
Yeah, no, they'll love that. I'm going to France in about 3 weeks. I'm sure they'll love that comment. So
Yeah, maybe you can edit that out.
no editing, no edits.
No edits.
Yeah.
Oh,
So when you
can I
think
ask you some
about,
questions? Can I ask you questions now?
yeah,
Would
what
like
do you
to
got for me?
What?
Sure, what do you got for me?
Well, I want to know, things change so fast in this space, right? We learn all these protocols, and we are always digging like for the most efficient, least expensive, um, most fully restorative path for healing for our patients. Um, Knowing what you do, how has your practice changed in the last 5 years?
Oh, so that's 2019. Well, I think
Like,
the
what did you
biggest,
used to use that you were like, you know what, that doesn't work for people anymore?
mm, I don't do gut cleanses with people anymore. Um, I don't do as much supplementation as I used to. I use a lot less supplements. I think that the biggest shift for me the last 5 years probably was, when you're young and you're like trying to figure stuff out and you're also like building a practice, um, protocols kind of make sense. And so you can get really good at protocols. They always say niche. You got a niche if you're going to build practice, because you need to be working with your demographic needs to find you, so to speak. And I never, my niche I thought was working with people that were stuck, and seeing a lot of different people, and like all these different practitioners were brilliant in their own way and had puzzle pieces to like a greater picture. And my role was to put all that together. But I think what's changed for me is I still was kind of in this fix it mentality of, okay, well, there's inflammation, so I want to deal with the inflammation. And where I've kind of really pivoted now is like, well, why? Not just why do they have inflammation, but is it correct? I now I'm kind of of the opinion that the body actually knows what it's doing, and it's doing so for a reason. And sometimes I actually promote inflammation with people to try to help them resolve. So there in inflammation, there's uh primary apoptosis, which means you resolve the inflammatory event, whether it's tissue damage or infection, something like that. Or there's secondary necrosis, where that tissue damage doesn't resolve, and that's where it becomes chronic and escalating and contributing to like telomere shortening, DNA damage, and neuro and degenerative processes. So I'm often asking myself, is this appropriate? Do I want to help this physiological process complete what it set out to do? Or is this a process that's gone off the rails and I need to help this person pull it off the rails? Like, for example, gluten-free for some people and dairy-free, and like dietary changes. I still wouldn't call it a cleanse, but that would be just something necessary at that point. I used to, I still do something called applied kinesiology, which is a diagnostic value system that uses muscle testing to help figure out what's going on. And one of the things that changed way before 5 years ago, especially as I started working with people with autoimmunity, was that muscle testing I found for those people to be less reliable in terms of like um, something you can, really depend on, because a person may strengthen to a supplement that their body is saying that it wants. So like I kind of got away from muscle testing and got into lab testing, but then I still do lab testing and I still teach lab testing, but now I'm more letting the history guide me. So I do deeper histories now. I do case reviews where I do much more histories, where I'm looking at like what's their home life, what is their support network. I try not to fail before I start by creating helping people with expectations about what we're trying to accomplish in this phase. The problem is time.
Yeah, always.
And also like, selective listening. I think I've had a number of circumstances recently, even where I feel like I was very clear at communicating something, and as it turns out, they heard something completely different. And even though I've even communicated in writing, it's not translating the way it was intended, because, there's kind of like a hope that it's something else, or there, you know what I mean? And so what's changed for me is I'm not trying to fix it. I'm trying to help the patient create conditions that are right to heal first, and understand, why is this process there? Why is the virus there if it's not supposed to be? Do I give antivirals? Okay. Or do I understand they have a blood sugar issue that's weakening their immune system? Well, why do they have a blood sugar issue? Well, because they're using food to help compensate for loneliness. Well, why are they lonely? Well, they're lonely because ever since their concussion, they don't feel like engaging in the world anymore. And now they also have neuroinflammation when they go out and do the things they love to do. Or maybe they're engaging in more alcohol than what their body can tolerate, because they're using it as a coping mechanism, because they're lonely because they have an attachment issue and they can't resolve that. And so then there's aspects of like addiction there, there's aspects of learned behavior. And so like it's so complex that what I try to do now that was different 5 years ago is I try to at least help people understand what we're dealing with from a systems survey, and just being open-minded about what it means, rather than saying it has to mean this if there's inflammation. And instead of saying I'm going to help you fix this, I try to say this is how we can address these particular systems. I can help you explore this territory in this chunk of time. These are the things that I can do for you. These are the things that you need to do. Are you willing to do that? Is it something you're interested in? We could start with one of these 5 things, like diet change, a supplement, going to your doctor, getting a medication if you need it, going to your doctor, getting off a medication if you need it, some sort of exercise. Are you willing to stop the exercise that you love to do in order to give yourself a chance to rest? Are you able to get out of that toxic relationship? Are you able to resolve that issue with your spouse? Are you able to get off porn? Like there's stuff that's just going on that's outside of labs, right? That are deeper issues. And it's so interesting listening to you talk about how the nervous system regulation is so important for your practice, because just the neurology of that makes sense. When you're in fight or flight and your nervous system is dysregulated, your vagina is going to get dry. Okay, you're not in procreation state. So yes, you can give the hormone cream,
Sure.
but you're going a step further and saying, what's going on here? So like there's something called the autonomic nervous system, fight or flight, rest and relax. There's this kind of old trope that one is on and the other one's off. That's not how it works. They go on at the same time. Okay. And if the sympathetic is too active, and it actually can shut down some of the sympathetic in the pelvis. So like if you're needing blood in your shoulders and hips so you can run, you're getting blood out of your frontal lobe so that you can be more emotional and have like motivation to fight or run. And you're getting blood out of your intestines and your liver, and you're getting blood out of your digestive organs and your organs for procreation. Then yes, sex is probably going to hurt in that moment if you keep having sex while there's no lubrication there, because there's no blood to that area. So like it makes total sense what you're doing. Start with nervous system regulation. And so I do that by doing a neuro exam. There's a lot of different ways to do that. This is an art form. And that's probably why you and I get along so well, is because we both want to change the industry. We see things that we don't like. We ask a lot of questions. We've been told as we were younger to just get in line. And now that, as you claim that you're gray, fine, but I actually have evidence of me being gray. I'm not being told as much. It looks blonde to me. Okay, but I'm not being told as much to just stand in line. And I've created my own model, basically. And I think that that's the biggest difference between me and 5 years ago. 5 years ago, I was still trying to fix everything, and I felt all this pressure was on me. Now I'm more like trying to collaborate with people. This is what I can offer you. This is why I think this is going on. This is why your body thinks it's completely appropriate for you to have a dry vagina right now. I do work with women that have
It makes sense to
similar
your
issues.
blueprint.
Huh?
It makes sense. It makes sense for the system where it is for you to have a dry vagina.
It would make sense
not
that
having
like
sex.
I would see a ton of that too, because how many women deal with that? Most women don't present to me with that as their chief complaint. I do work with a lot of women with aerobic vaginosis and bacterial vaginitis, and co-managing them to try to help them with that. But the deal is the reason that so many of these things are chronic is because their parasympathetic control is being shut off from dominance of this other system, and they're not in the capacity to heal. So they've been on all the BV medications. They've been on what is it, methimazole? Like, what is the thing that's primarily given for BV?
Metronidazole.
Metronidazole. That's what it is. That's right. So they've been on that a million times. They've done their own
Boric acid suppositories.
boron. They've done all of it, and it just keeps coming back. And it's because they've wiped out their healthy microflora due to poor circulation and due to chronic killing of everything, and they don't have healthy flora. That's what AV is. Aerobic vaginosis is absence of healthy flora. So there's a great profile, AVBV profile from medical diagnostic labs that I'll run with women that are having chronic issues there. And it turns out that most of them don't have overgrowths of infections. They actually have a lack of healthy bacteria, but it's not just enough to give them a suppository for the bacteria. We have to figure out, why don't they have blood flow to that area? And they'll tell you they have painful sex, they have vulvodynia, they have dry vagina. Some of them have odor and discharge that didn't used to be there. Some of them have an IUD in, and the IUD is basically got copper right there. It's wreaking havoc, and until that comes out, nothing will work.
Hormonal IUD that's suppressing their hormones, and they're not actually producing hormones that actually promote blood flow.
Right. So anyway, I'm just rambling now, maybe going on.
No, but I want to say this is I see this all. I mean, I'll let you finish. Go ahead, finish.
No, I think I just went on a rant. So hopefully that answers the question. But it's really about understanding. Look, this is appropriate. Why does the body think that's appropriate? I don't need to fix your body. I need to help your body understand what it was meant to do. The brain is actually what tells the body to go back to homeostasis or balance. The brain through a process called allostasis. And I feel like so many people have frontal lobe issues. They have attentional issues. They have sleep issues. They have anxiety. They have depression. They have memory issues. They have all these frontal lobe executive function issues, and nobody's looking at that. They're looking at that from the gut. The gut's causing it. And it's bidirectional for sure. In fact, it's not even different systems, but there's so much top down that can be done. And I feel like when I got out of the way and I understood gravity is a stress for people, and they just can't even get up without being stressed because their blood pressure is all over the place when they change position.
Right.
And we fixed their relationship with gravity. It's amazing how much less stress they have. And it's like, I'm working with a client right now who literally, we fixed their relationship with gravity. So they're no longer like having like issues when they stand up, and they're no longer like experiencing like movement when they're not, or like they're tipping over when they're not. But their immune system is so happy now not to be suppressed by the stress chemistry that they fought off an old pneumonia they had since they were 11. And now they're currently fighting cytomegalovirus. They're sweating at night. There are HRVs in the shitter. And they're frustrated because, they got trips coming up. They have stuff they want to do with their life. And now they're going through a healing crisis. But I have the confidence to say your body actually is doing what it thinks is appropriate. And now it finally can. So just hang in there.
Yeah. Well, I think that what I've seen, and I don't get to experience this all the time, but when those people start having these healing crises where they start, it's like we call it whack-a-mole. It's like you clear one thing and then the other thing that, pops up. And the way that I phrase it in clinic is like, and this is the thing that I've been meaning to talk to you about. Your body's like, hey, so I know you're busy, so I want to say this for later. But I really feel like that so much of that illness, like that healing crisis and all those symptoms can be mitigated and prevented by really addressing those foundations. And I'm not just like tooting the foundation's horn, but like we are so willing to compromise on the food that we eat. I mean, we won't the money that people spend where they choose to prioritize their finances. I mean, and I'm not criticizing, but just like watching, observing, right? But nails and clothes and like the expensive things in life, but then they'll complain about the expensive organic food. I mean, that's a huge issue. Like that is a huge issue. And so that's why the core of what we do, it's self-love, self-acceptance. Zach Bush says you can't actually completely have self-love, but self-prioritization. And that alone can actually help regulate the nervous system. And then you can start working on these foundational things before you start doing a protocol to clear viruses or to clear bacteria. It's like we have to remind the body of the blueprint of like what it was meant to do. Like you are meant to lift weight. You are meant to walk, distance and up hills. So
easier time with that. I think women in particular need that guidance. They put everybody in front of them. And so I do see that a lot more with women, right? I mean,
one of the sort of guiding lights for me, pardon?
Go ahead.
Well, one of the guiding lights or guiding memories for me was the Dalai Lama came to Seattle and did this 5-day Seeds of Change program. And he'd been quoted about this before, which I found out later, but I was at the University of Washington in the basketball arena. And so somebody gave me a ticket. I went there with my son, and we're like, if you have an arena like this, he was at like one of the goals and I was right across. It was like so close to the Dalai Lama and Desmond Tutu. And he said this, I mean, I wasn't like, we're there on the court and we're in the stands, but he said that the Western woman is going to change the world. And I was like, oh, and I can see that like he elaborated a little bit, like the mothers, the way that we're mothering our children now and the health of the women in the Western world will have influence throughout the world. And I have goosebumps. And I've seen that in other places. And he says, not all women. It won't be every woman, but it'll be the women with fire in their bellies. And so this is something that I've taken to heart. It's like, it's my job to help these women reclaim their fire in their bellies, whether that's digestive fire, whether that's soul purpose, whether that's getting joy from something other than food or TV or gossip or complaining, whatever it is. But it really is about finding yourself again. You know, Kelly Brogan she's all about reclamation. Kelly Brogan, the psychiatrist, who has kind of, you know, gone rogue in a really positive way. We have to kind of claim she says, claim our birthright, but, you know, claim the blueprint. Like, I am all about the primal structure. Like, what were we made to do? We were made to run, walk, lift, harvest, chew, not eat a ton, be up when the sun is out, be sleeping when the sun is down, and honoring those old patterns, those circadian patterns, those primal patterns, because the reality is the world that we live in was not made for us. You know, we have an old blueprint that has not evolved to the stimulus, to the seed oils, to the distraction, to the electronic devices everywhere. We just haven't evolved to accommodate, to cope with this. And so no wonder our nervous systems are totally fried. You add a little trauma from your childhood onto that, and you can't heal anything.
It's like running too much wattage through a circuit that can't deal with it.
That's exactly it. Capacity. We are trying to operate well beyond our capacity.
Yeah. In a way, our life is easier than it's ever been, but with all of the things that are outside of what our body was built to deal with, like sitting all the time, xenoestrogens, Wi-Fi, all the stuff you're talking about, the stuff we put on our skin, the amount of media we take in, just having an antenna next to your head. There's so much going on
You talk about your brain.
for our body. It's no wonder. So the things that you can modify become that much more important, because some of the stuff.
That's it, Joe. That's it right there. Exactly. What do I have control over? What can I modify? What I put in my mouth, the thoughts that I allow to move into action. I can control that.
Well, that's the beauty is there is choice. There is choice. And I feel like that's the biggest thing that's missing in our field is informed consent. And also, like, you know, like what we we're talking about earlier, like I do feel like as much as like patients need to have the information to make the choice, they have to be willing and able to accept that. And sometimes they are like, oh yeah, I can do that. And then they kind of see that it's not like your body accidentally, this stuff happened. Like your genes think because of your environment, this is appropriate. Some of these things happen to you. It's not your fault. It's just living in the world that we live in right now. And we got to do something about it. I understand. But some of these things are under your control, and stepping out of and this is going to trigger some people. Okay. But like, there are some people out there that are stuck in like this kind of victim mentality of this happened to me, it was unfair, and those things could be true. And what's next? What can you do about that? What are you willing to do about that?
You still get to write the story, right? You get to claim the narrative that you want to claim.
Right. They have to have good advice, but they got to be willing to accept that and implement it and try things. And I think that's where we live in a world where Ozempic is like one of the number one drugs right now. The thing they're willing to try is the thing that's going to get them the results they're looking for without any extra changes. And who wouldn't want that? But it's unfortunate because the consequences of that end up, it's almost like a genie, like literally a genie granted you this wish of weight loss. But like, it's just like the old fable, like, yes, you got your wish granted, but it came with more loaded dice than you thought.
Right.
And this isn't, I swear to you, it sounds like it. It's not a judgment. It's just more because we're colleagues. I'm kind of venting about it a little bit because I just, I'd like to come up with a more viable solution than painting over rust.
Yeah, I agree with you. I hear your frustration, and I agree with you. I think that because of the nervous system dysregulation, because of the overwhelm, sometimes people need a win.
Yes.
And I know that you do that too. We'll start people on supplements or medication to get the system going, and just to breathe, just to not have to battle gravity. And I think that I think having not a psychological assessment like an evaluation, but just having important conversations with patients. Um, Informed consent, yes, like all the things that can happen to your body, but also like, what's your plan beyond this? Like, we can do this, but like, are you going to work with a nutritionist? Are you working on your stress? Are you going to build lean body mass? What's your plan for that? And I mean, everything has its place, and that's the deal with medicine. It's meant for triage, triage, treatment, and stabilization. And so, that's conventional medicine. That is what it was designed for. It was never designed to manage chronic illness, because there was no such thing.
Paradigm problem. Exactly. We're relying too much on our doctors for it. We're asking too much from them. Same with the alternative medicine doctors. But I believe that even though you can't prove prevention is possible, we're all going to live or die, but we can have an influence on what our quality of life is and that of the people around us. So,
well, I think just to come back to choice, right? It's like, if you want to be vital, if you want to make it to the top of the mountain so you get to see the view, if you want to live to see your great grandchildren, if you don't want to go into an assisted living facility, if you're clear about that, then you're going to be more motivated to do what it takes. And we see it. There are two kinds of patients that walk in. There are patients who are like, I'm okay. I know I've got all these things, but like, I'm okay. And the other people who are like, just tell me what to do and I'll do it. Maybe that's not just two patients. There's probably a lot of in between.
Those are two distinct categories for sure. I think there's more, but you're right. They're definitely out there.
Yeah.
Well, this has been fun.
Yeah, it's great.
Any other questions? Anything that?
Yeah, but I think that the things that I'm curious about, you answered a lot. I mean, it is. I think I'm in a bit of a silo, right? Because I'm in the conventional medical model, and to hear that like you're still getting this like crap, right? You're still getting flack, or you're still getting questions from your patients, or they're, I feel
but it does happen sometimes.
Yeah, I know you don't get a lot, but people in functional medicine and in chiropractic and in naturopathic medicine, it's still happening. You're still battling a little bit more, and I firmly believe that like naturopaths would be a great first line primary care. It's like you're, having someone who's trained in nutrition should be in the primary care position. But
yeah, nutrition's a big part of it. Mm-hmm. But it sounds like what you're doing can be a big part of transforming the industry, so it becomes more of a systemic approach rather than the current, RDA model.
That's our goal. And the next thing on the horizon I'm really excited about is I've been given the green light for the employee health program. So we're going to put our employees, our staff, who, everyone's surviving on energy drinks, but they are going to go through the metabolic wellness program. That's
awesome. Be the change you used to see kind of thing, huh?
Yeah.
So. Cool. Well, let's talk about that more next time, and hopefully I'll have my studio set up and we can drop the Zoom and do this in person. So we'll make sure that your information and everything, so people can find you, is in the description of this video. So thank you so much, and I'm looking forward to the next one.
Thank you. Great time. Appreciate it.
See you.
I just dropped in to see what condition my condition was in. I just dropped in to see what condition my condition was in.